Одна из целей создания израильского медицинского центра была внедрение инновационных технологий в сфере медицины. Этот путь мы начали с профессором Ливраном в 2008 году, когда открыли первую лабораторию ВРТ. А теперь я хочу приветствовать эру генетики в Узбекистане. Совместно с Министерством здравоохранения мы дадим возможность населению Узбекистана проходить скрининг на носительство заболеваний, преимплантационную диагностику и также неинвазивную перинатальную диагностику. Мы сможем более точно диагностировать и предсказать онкологические заболевания с помощью анализов как TrueSight и за счет этого оздоровить нацию. Наша генетическая лаборатория является уникальной в ее сфере в Узбекистане и в Средней Азии. Мы единственные, которые сохраняем всю технологическую цепочку производства на местной основе. Мы единственные, которые делают секвенацию генома, экзома PGTA, PGTM по системе CGH и также NAPT на территории Узбекистана. Мы внедряем роботов, которые нам помогают автоматизировать процесс, и также Artificial Intelligence, который нам позволяет улучшить качество наших результатов. Весь этот путь приведет нас к тому, что через короткое время Узбекистан станет лидером в сфере генетической диагностики во всей Средней Азии и также в постсоветском пространстве. Узбекистан всегда был сияющей звездой Средней Азии, и с внедрением этих технологий он будет сиять еще сильнее.
Your Excellency, Vice Minister of Health, Mr. Ulukbek Sabirov, Her Excellency, the Ambassador of Israel, Zavid Ben Hillel, Ms. Nigora Muratovna, honored guests, dear friends and colleagues. First, I would like to thank you for attending our event. Today it is an honor and a pleasure to host you. Today I'd like to introduce you to the world of genetic testing, an intrinsic tapestry of woven the threads of science and medicine, illuminating the hidden facts to personalized healthcare. These remarkable technologies enable us to examine our genetic blueprint in an extraordinary detail, help us understand the causes of disease, develop new treatments, and even predict individual risks for certain conditions. Genetic testing presents us with incredible possibilities. It is a powerful tool in our ongoing journey of understanding the human body, improving health outcomes, and delivering personalized healthcare. As we move forward in this crucial experiment with excitement and responsibility, cherishing the potential benefits while considering the ethical implications of this evolving field. It is very important for us to understand that genetics itself can be very helpful and at the same way can be very harmful. And this is our responsibility as physicians and as Ministry of Health to take care of these problems and advance this field in its correct direction in the Republic of Uzbekistan. Thank you. Mr. Vice Minister, please.
Assalamu alaikum. Dear ladies and gentlemen, good afternoon. Dear Madam Ambassador, dear participants of the conference on evaluating the medical system in the country, first of all, we take into consideration medical services provided to mothers and children. During the short period of time in our country, when it comes to healthcare for women and girls, we conducted a number of the reforms. The first most important goals were in line with the standards proposed by the WHO was related to increasing the quality of the healthcare services and also increasing the number of the maternal child care facilities and also improving them in terms of the staffing. So in line with the decree of the President of the Republic of Uzbekistan from the year 2022 on establishing services and providing free of charge provision of medicine to the ones who have the spinal diseases. We have conducted a molecular type of the laboratory checks of the biomaterials taken from the pregnant women for the molecular diagnostic. In order to conduct the effective management of the, we have established a single national register on this type of diseases. Republican Center for Screening of Mother and Child and regional centers, including the one in Karakalpakstan, in Tashkent city, they were provided with computers and also connected to the internet. In the first primary healthcare areas, we have the women's consultancy for the pre-pregnancy and pre-delivery works are conducted. All those in the risk group on the spinal diseases, they undergo the primary diagnostics and screening, and also that will be followed by the free of charge diagnostic at the Republican Center of Screening of Mother and Child, and including as well as regional centers in the Republic of Karakalpakstan and regions in Tashkent city. And modern molecular genetic national labs and reference labs of the National Pediatrics Scientific Center. Starting in July 2023, young people establishing their families, they will undergo and the special centers and in the regional centers as well as in the Tashkent city. And this molecular genetics examination will be conducted and at the national specialized hematological center, the results of which will be included into the single national register of personal data. Taking into consideration that this takes to conduct a wide range of the awareness raising campaign, taking that into consideration, Minister of Health of the Republic of Uzbekistan together with the Medical Center of Israel has been conducting a number of activities on the improving the knowledge of population on this kinds of diagnostics, and a number of the mini conferences were conducted. And we know that this mini conferences aim at prevention and informing, because it's much better than suffering at the later stages, and because it's even harder when you see the parents watching it, and it's going to be also difficult for the government to take care of it. That's why this kind of conferences aim at genetical diagnostics and examinations, aim at timely identification, and diagnostics are very important. That's why I believe that today will be enjoying the lectures where those studies, as we heard, those will be about invasive and non-invasive type of actions where possible. I believe that's going to be more about non-invasive methods, because people are usually afraid of the invasive types of work. That's why it's quite difficult, considered quite difficult for bearing. That's why I believe that today's conference bring a lot of new knowledge, and will help people to get rid of the doubts, and it will help in the future that will be identifying on a timely basis different types of genetical anomalies and the diseases at the early stages, and we'll be able to prevent this kind of disease, and we'll be able to build and form our healthy society. Dear colleagues, I would like to congratulate you with the opening of this conference. I believe together with the Israeli company, this conference of our gynecology specialists, genetic specialists, will be provide good results. Thank you.
Я хочу представить нашего первого спикера.
I would like to invite our first speaker, Professor Kostov Malinger, one of the famous obstetrician in Israel. He is obstetrician gynecologist, specialist in ultrasound diagnostics. He's proud if he says that everything is okay with child, then it's all good. If Professor Malinger says that the pregnant women are good, then the woman is good. That's why let's listen to our professor with greatest enthusiasm. No sound to translate.
Hello. It's okay? Hello?
Yes, Professor, we can hear you.
Okay, and you see the mouse?
Yes.
Okay. So, good afternoon here in Israel, good morning. I'm very grateful for the invitation to participate in this meeting. And I am going to speak a little bit about one of the most important indications to perform further genetic tests in pregnant women, and I'm going to speak about my approach to fetal ventriculomegaly. Fetal ventriculomegaly is the most common anomaly of the central nervous system that is diagnosed during fetal life. The prevalence of ventriculomegaly varies between 0.3 to 1.5 per 1,000 births, so it's quite common. And when you have a patient, a fetus that have isolated mild to moderate ventriculomegaly, this is linked to an abnormal outcome in around 10 to 20% of the children. It depends on how extended is your follow-up protocol, but these are the numbers in the general literature. But also ventriculomegaly is associated in many cases with anomalies that can be part of more complex syndromes, and in these cases the prognosis of the children of normalcy is less than 50%. Ventriculomegaly is important because usually it's the first indication that something in the fetal CNS system is wrong. On the other side, we need to understand that most children that have isolated ventriculomegaly, mild to moderate, will develop completely normal. So why we do the prenatal diagnosis? The prenatal diagnosis in this case is important because it helps us to guide pregnancy, it helps us to make decisions regarding the mode and time of delivery, also to prepare for optimal prenatal, perinatal and postnatal care. And finally, we need to be aware that in these cases, the prenatal diagnosis may support information regarding new intrapartum intervention, as an example, repair of meningomyelocele, and also the possibility, when it's permitted in some countries, to perform termination of pregnancy. Now, let's start with the definition. What is ventriculomegaly? The normal width of the lateral ventricle should be between 3 and 9.9 millimeters. We define mild ventriculomegaly when there is between 10 and 14.9. There are some authors that change a little bit the definition, mainly during the third trimester, and these people think that mild ventriculomegaly should be only when the lateral ventricle is more than 12 millimeters. We speak about borderline ventriculomegaly between 10 and 12 because what I explained previously, severe ventriculomegaly is when the lateral ventricles, one or both of them, are larger than 50 millimeters. We speak also about asymmetry of the ventricles, when the difference between the two lateral ventricles is more than 2 millimeters. That is quite common. And asymmetric ventriculomegaly is when one or both ventricles are larger than 10 millimeters but asymmetric. Now, something that is extremely important is how we perform the measurement, because there are a lot of situations where we found measurements that were not correctly done. the measurement should be in at the level of the atrium of the lateral ventricle. You should not measure in the occipital horn, because if you measure in the occipital horn, the measurement may be 11, 12 and be completely normal. So it's important to measure in at the level of the ventricular atrium. The measurement should be perpendicular to the lateral walls, not something like that. And again, I repeat, important in measurement. The most common pitfalls in the diagnosis of malventriculomegalia are errors in measurement. When you measure in an oblique plane, particularly the proximal ventricle, because it's difficult to see the lateral ventricle because of the bones that make a reverberation. When you put your calipers and include the brain, or when you measure in the occipital horn, that I told you previously, can be much larger and be completely normal. There is also the possibility that there will be a resolution. You measure 10 millimeters, and after a few days or weeks can be less or more. And the other important issue, that since the proximal ventricle is difficult to visualize because of the reverberance, a lot of times we don't see that this ventricle is abnormally large. But the most important pitfall in the diagnosis of ventriculomegaly is the failure to detect associated anomalies that are quite common, and this will be the main point of my lecture. How to try not to miss these associated anomalies that we know, everyone that works in the field knows that this is not possible in 100% of the cases. Now, the differential diagnosis of non-isolated fetal ventriculomegaly is very extended. It included syndromes associated with extraneal findings. A lot of times it happens that you look at the brain, there is ventriculomegaly, you see nothing else, but you forgot to continue studying the whole fetus to see if there are no other associated anomalies. Can be chromosomal disease, can be associated with malformative structural brain anomalies, including and mainly corpus callosum anomalies, posterior fossa anomalies, cortical malformations, septal abnormalities, abnormalities of septum pellucidum, and Dandy Walker malformation. But it's very important to remember that not all the ventriculomegalies are due to genetic conditions, but sometimes they can be a result of insults. The insults themselves may be genetic, but you need to think also in intrauterine infections, intraventricular hemorrhage, inborn errors of metabolism that are very rare, hypoxic ischemic injury of the fetus, and also possibilities that ventriculomegaly is caused by external compression by an arachnoid cyst or a tumor. Now, this is the flowchart we developed and we published recently in our book, the ultrasonography of the prenatal brain, was published in February 2023, so it's quite actualized with the collaboration of friends, Anna Monteagudo, Gianluigi Pilo, Dario Palladini, and Ilan Timor Tirch, that are, in my personal opinion, the best persons working in the field all around the world. And this is the table that we do. So, how we study the case? First of all, as I told you before, you need to measure to make the diagnosis, okay? And the dilatation can be symmetric, as you can see here in this fetus, that the lateral ventricle is measured 10.5 millimeters, or it can be asymmetric, where here you have a large ventricle and a small one. So the first step in the evaluation is to be completely sure that your measurements are correct. Because if the measurements are incorrect, you put the patient in unnecessary stress. You can tell the patient, no, look, the measurements now are okay, go ahead. Now, step 2 will be to look for 2 important structures because they are commonly associated with ventriculomegaly. So we ask 2 questions. Are the infratentorial structures normal? And the second question will be, if the corpus callosum, cavum septum pellucidum complex are normal. Okay? So we ask if there are normals, and now we look at the cerebellum. Are the structures normal? No, they are abnormal. You can see here in these 2 fetuses that the cerebellum is abnormal because there is a condition called rhomboencephalosynapsis, where there is missing vermis or completely missing vermis, and you can see the folia of the cerebellum going from one side to the other without the vermis in the middle. Usually the shape of the cerebellum in these cases is rounded instead of having the shape of a half-8. Other possibility is cerebral hypoplasia. You see here that the shape of the cerebellum is okay, but the size is very small. At 21 weeks and 4 days, the cerebellum is a cerebellum of 17 weeks, very small cerebellum. Or here in this case, when the TCD, the measurement from one side to the other is normal, but the height of the cerebellum is short, what's called the dragonfly pattern, that is very characteristic of cerebral hypoplasia. And here you have a fetus with Walker-Barbour syndrome. That is a genetic condition where you see at 16 weeks that the shape of the brainstem is not straight but have a Z-shaped form. Or this is a case of a Dandy-Walker malformation that also, even it's very early, this fetus is abnormal because they have a lot of other anomalies as diaphragmatic hernia, Fallot, tetralogy Fallot with severe pulmonary stenosis. The kidneys are echogenic, and there is also very early IUGR, so you know for sure that here there are associated anomalies. Okay, and the second question, is the corpus callosum cavus septum pellucidum complex normal? You see here at 29 weeks, a fetus has complete agenesis of the corpus callosum. I don't need to go and look for the corpus callosum because this shape of the lateral ventricle with very sharp anterior horn is almost pathognomonic of a pathology of the corpus callosum, but sometimes the lateral ventricle may be normal, a little bit dilated, but with a short corpus callosum, as in this case. You see the corpus callosum at 38 weeks should be around 4.5 centimeters, and here you have a corpus callosum that the length is only 1.52 centimeters. And the other possibility is that the corpus callosum can be normal, but there is agenesis to the septum pellucidum. The leaflets of the septum pellucidum are not present, and this is another condition that needs to be further studied. So if after doing step 2, both questions are normal, okay, we go to step 3. Step 3 is to look at the cortical development of the fetus, of the brain. And there are many conditions that can give us a diagnosis. The answer in these cases is no. At 27 weeks and 3 days, you see that the sulcation is asymmetric, abnormal. This fetus has a very large head circumference of 2.2 standard deviation, and you see also the shape of the lateral ventricles that is rounded, large, and abnormal, with a large third ventricle. In this case, the fetus has a macrosomy and a macrocephaly syndrome. Here you have a fetus at 16 weeks and 6 days, very early, but you see that the whole brain parenchyma is abnormal, it is not continuous, so you can say that here there is a very severe condition, most probably a condition called hemimegalencephaly. And this is another case at 32 weeks where the walls of the lateral ventricle are irregular with these bumps here, and this is a case of nodular heterotopia. If the answer to the cortical development are normal, we go for step 4. And step 4, we ask for acquired CNS conditions. Are acquired CNS conditions ruled out, yes or no? If the answer is no, it can be cytomegalovirus infection, where the brain is quite atrophic. There is a lot of fluid in anterior portions of the brain, and you see here very clearly the calcifications. It can be an intraventricular hemorrhage, intraventricular hemorrhage grade 3, where you see the clot, the blood clot that are stuck to the walls of the lateral ventricle, to the endothelium, and this is with ventricular dilatation. This is a case of intraventricular hemorrhage grade 3, and this is a fetus that is a twin pregnancy at 24 weeks and 6 days that without knowing that it's a monochorionic pregnancy, the physician performed selective feticide, causing severe anemia in the surviving fetus, and also with brain destruction and the formation of a porencephalic cyst. Are acquired CNS disease ruled out? The question is yes, we have ruled out almost everything that can be possible as in the brain. So we need to remember, I put in red because it's very important. A lot of time we forgot to look at the rest of the fetus, so you need to rule out non-CNS anomalies. If you are able to, as sure as possible, rule out CNS anomalies, okay, we are speaking probably of isolated ventriculomegaly, but there is one more step that is important. You say, okay, now this is probably isolated ventriculomegaly. Now you go back and you look to the biometry. And you should ask yourself, is the head circumference normal or large? Or is the head circumference associated with mild ventriculomegaly small? If the head circumference is normal or most preferably large, the prognosis will be usually good. If the head circumference is small with mild to moderate ventriculomegaly, you should think about microcephaly or other conditions with poor prognosis, because you expect that if the lateral ventricles are dilated, the head should be a little bit larger than expected, not smaller. And the question is, does this approach work on everyday work? I'm going to show what I call a case of the day. Which anomaly is the most difficult to be diagnosed after you diagnose something wrong, and always the anomaly that is most difficult to be diagnosed after the first one is the second one, because you will never be completely sure 100% of the cases that there is not something that you are missing. And this is a patient that is 29 years old, gravida 1 para 0, she's healthy, no relevant history. She underwent normal look-at translucency. She did a triple test, was normal. We performed an examination at 15 weeks that was normal, but she was referred to us at 24 weeks because of mild ventriculomegaly. They wrote that there is apparently isolated ventriculomegalia, and they were not able to exclude an all intraventricular hemorrhage. So the patient come to us for second opinion ultrasound. And when we look at the lateral ventricles, we measure the one lateral ventricle at 27 weeks, that is 11 millimeters, the other one is 30 millimeters, so it's clearly you have asymmetric mild to moderate ventriculomegaly. And this is the video when you do a transabdominal examination, and this is very important. We're going to speak about that a little bit later on, that it's not enough to do a good examination of the brain only using transabdominal one, and you need to do a transvaginal. If the fetus is in bridge position, try to make a version and do the examination transvaginal. Okay, and again, you see that the TCD is normal, the cerebellum appears normal, the vermis is normal, the foreventricle appears normal, the pons is here and is normal, the corpus callosum is normal, the measurement of the corpus callosum is normal. But look what happened with the fetus. I am going to show it again. Okay? We know that by now the anatomy is normal, we find nothing else, but you see that the fetus has a very abnormal movement, a very abnormal pattern of movement that is suspicious of an epileptic fit, of a convulsion. So we know that here something should be fine because the fetus is not doing well from the physiological point of view. He's having abnormal movements. And when we go for the transvaginal, and you see at the transvaginal, you see that one of the leaflets of the septum pellucidum is normal, but the other one is disruptor or genetic, meaning that here the prognosis is worse than expected because of the abnormal movements, because of the absence of the partial absence of the septum pellucidum. And if you look here, you see what's called the basal cistern. The basal cistern is a subarachnoid space, but here in the basal cistern you always should see something. You should see some structures there. It's not completely empty, and what is missing here is the chiasma. The optic nerve is missing, meaning that this fetus has most probably a condition that is called septo-optical dysplasia. That is a very bad condition because it's associated with mental retardation and also with severe endocrinological problems, and this child are blind. So we finish our targeted ultrasound examination. The question is, have you finished by now our investigation? No, because always we need to do by ourselves or refer the patient for a fetal echocardiography, we need to have genetic consultation, and this is what's important. This is where I enter the conference today. We need to include in the examination, or we need to recommend to do an amniocentesis or a CVS, usually it's amniocentesis because it's late in pregnancy, and to try to obtain a karyotype, if possible, a CGH, a microarray. But today, we think that the first tier in this case should be exomic sequencing, because the yield of exomic sequencing is higher than the yield of CMA, and usually is large than the yield of karyotype. And in most cases, there is a problem in CGH, in the microarray. We'll be also able to find this in the exomic sequencing. We need to ask if there is a suspicion to do torch examination, mainly in my country, cytomegalovirus. In other countries, toxoplasma may be more prevalent. In countries where there are large agricultural workers, also you need to think today in choriomeningitis virus. And the last thing that we do with everything is, okay, we can find a reason for the ventriculomegaly, we need to consider the possibility of do a fetal brain MRI. Now, the question that should be asked, and I am going to try to ask, some of them I ask you now, is following the diagnosis of ventriculomegalia, should patients be referred for neurosonographic examination? The answer is yes. We spoke about that. Should a TVS scan be performed? Again, the answer is yes. We spoke about that. Should MRI be considered as part of the assessment if everything is okay and you find nothing and you are sure of the examinations? It can be done or not, but it depends on the quality of the examination, how sure you are about the normalcy of the brain. If you are not sure, the examination is difficult if the patient is in breath position. In this case, you should consider to do an MRI, not because of the quality of the MRI comparing with the neurosonography, because of the possibilities for MRI to see things that were missed in your not so good ultrasound examination. Should serial examinations be arranged? Yes. Our stand-up recommendation in the protocol is that every patient that is referred for a brain condition and we see that everything is normal, always we order a second examination at 3 to 4 weeks to be sure that we ourselves have not missed something. Should screening fetal infections be performed? Yes, I told that to you. Should CMA or exomic sequencing be offered? And again, the answer is completely yes. And if you can, start doing exome sequencing and let the CMA for later on if needed. The important question regarding all the follow-up is who performed the ultrasound, when was the ultrasound performed, because if you make diagnosis very early and the patient decide to continue pregnancy, again, you need to do later on examinations. Which approach was used, transvaginal should be done, and which question were asked. So if you don't ask the correct questions, you will never reach diagnosis. Now, what is in the literature, and this is one important paper, it's a paper that was published by a group in France of Professor Catherine Garret in 2006. It should be said that the examination were performed only at abdominal using a 5 MHz probe, and they have a very large group of fetuses that underwent unrelated to the moment that the ultrasound were performed. They wait until 30 to 32 weeks to perform the MR. And when they performed the MR at 30 to 32 weeks, in 1/4 of the cases, the ventricles were normal. Okay, were errors in measurements or regression of the lateral ventricles. In 106 cases, more 60% of the cases, the lateral ventricles were between 10 and 12. And in the 36 cases, 20% of the cases, the ventricles were larger than 12 millimeters. Most of them were unilateral. In these cases, the MR was able to recognize another 5 anomalies that are 4.7% of the cases. Plus here, in cases where were severe ventriculomegaly, the MR diagnosed an additional 6 anomalies that are 17% of the cases. Now, what what I did is I went to the tables and I looked what was missed by the ultrasound. And you can see here that all these ones that are with these lines can be diagnosed by ultrasound because we are able to diagnose germinolysis. Perhaps the germinolysis occurs later on after the ultrasound examination. Irregularity of the right ventricle. I show you the possibility to make diagnosis of heterotopia. And also it's important to recognize that 3 of the children were born and are completely normal, even when the MR saw some kind of anomalies. They conclude that after targeted fetal ultraexamination screening, one could expect that MRI will provide information in 4.7% of the cases between 10 and 12. Without offering MRI, in 6% of the cases, the diagnosis will be missed. And this is something that the parents need to be informed about. The possibility that MRI will add 6%, in 6% of the cases, additional findings. But later on, speaking with Catherine Garel, that is one of my friends, she recognized that using modern ultrasound equipment based on transvaginal examination, most of these cases should be diagnosed also by ultrasound. What happened regarding the development of the children? They have a follow-up of 167 patients. In 4 of them, there were chromosomal anomalies diagnosed by amniocentesis, and 2 patients were diagnosed also by amniocentesis having CMV. MRI diagnosed brain-associated anomalies in 50% of this case, in 50 patients of this one, again 10%, but the ultrasound follow-up after the MR diagnosed the malformation added other malformations. TOP was considered in 12% of the cases. From the patient that have a good postnatal follow-up at 19 and 127% of the cases, 12, again 10 to 12% have some kind of neurological disease or psychomotor delay. 89% of the patients were normal, and the association between the neurological disease or psychomotor delay, these cases were associated with a lateral ventricle that was bigger than 12 millimeters. When there was asymmetric bilateral enlargement, both lateral ventricles were asymmetrically enlarged, or when there was progression of the ventriculomegaly. It was not something static, but through pregnancy, the ventriculomegaly becomes worse. There is another paper, that this one from Italy, where they study fetuses at different gestational age. Again, more or less the same number, 179, at different gestational age. And they found, the prenatal findings, they found that most of the cases, 73%, there was truly isolated mild ventriculomegaly. In 5% of the cases, we reached almost 80%, there was no ventriculomegaly, but in around 20% of the cases, or 80, it was isolated moderate ventriculomegaly, so the ventriculomegaly progresses, and in 35% of the cases, they found additional findings. Okay, so you look at this number, they show 35% of the cases have additional findings. What were these additional findings? Okay, they are here. Increase of cranial diameters in 22, okay? Okay, should you do an ultrasound at the same time, you will see the increase, because to measure is something that you can be done by ultrasound or by MRI. Linear subependymal T2 weighted hypodensities is in 6% of the cases that they have not in postnatal MRI, so this finding is of not importance because postnatal MRI was normal. Enlargement of the cisterna magna should be diagnosed also by ultrasound. Reduction of geometric parameters, again, should be done by ultrasound. And there were only a single case of schizencephaly and septum pellucidum agenesis, that the child passed away as intrauterine fetal death, so the MRI failed to contribute also in these cases, and there was one case with septum pellucidum agenesis. Okay, the postnatal follow-up was abnormal in 3.2% of the cases, the case of schizencephaly and septum pellucidum, and other cases that have other anomalies that were missed also by ultrasound and also by MRI. The conclusion of this paper is that MRI could be excluded in the prenatal imaging protocol without a significant impact on counseling. Now, what are the prognostic factors? The prognostic factors are the association with other anomalies not detected at the first examination, the progression of ventricular dilatation, measurements in excess of 12 millimeter that can be associated with a worse prognosis, but still there is no strong evidence supporting this opinion. Asymmetry of the ventricular system may be a prognostic factor, but needs to be assessed in larger population. Now, there are some exceptions where you see measurements of the lateral ventricle that are suspicious of ventriculomegaly, but very early in pregnancy. And in this case, at 15 weeks and 3 days, you see severe, in our opinion, severe ventriculomegaly. Although the lateral ventricle is only 11, but you see here that the choroid plexus are very contracted, and we were not able to see the aqueduct in any of the planes that you use. So this aqueductal stenosis and this fetus have also not only this finding, but also an AV canal in the heart. This is another case where the lateral ventricles are measured 11 millimeters at 11 weeks, and this fetus turned out to have Down syndrome. And what is quite clear is that there is quite a lot of fluid around the brain, but the diagnosis was made by amniocentesis. And here you have a fetus that have a large lateral ventricle. The choroid plexus is dangling. There is liquid between the choroid plexus and the lateral wall of the lateral ventricle. These cases should be followed up because by this time we cannot reach a diagnosis. But you should follow up when you see that there is a lot of fluid around the choroid plexus. The counseling in isolated mild ventriculomegaly should include isolated mild ventriculomegaly is diagnosed of exclusion because the prognosis can be altered drastically depending on the coexisting anomalies. Expert ultrasound examination is needed. Detailed fetal neurosographic evaluation should be performed by a multiplanar transvaginal approach with a high-resolution probe. Isolated ventriculomegaly can be associated with abnormal cerebral development, which may be better demonstrated with fetal MRI. As I show you in one of the papers, this is not true, but today the recommendations say, mainly for legal medical purposes, ask to perform an MRI. At the examination advantageous analysis of sedation, MRI examination should be done later on because you cannot make a diagnosis of abnormal sulcation in most of the cases, not in all, between 30 and 32 weeks. Given the possible association with mild ventriculomegaly, the difficulty in early ultrasound detection of fetal infection, the worded prognosis in cases of affected children, the potential for treatment, and the simplicity, safety, and relatively low cost of the screening test, maternal serum CMV and toxoplasma studies should be considered. Given the strength of the association between mild ventriculomegaly and chromosomal abnormalities, it is recommended to perform a karyotype, CGH, or preferably, if you can do that, an exomic sequencing. Limitations in capability of ultrasound imaging differentiate between truly isolated ventriculomegaly from the associated with something with another anomaly is in the region of 13% of the cases. Thank you very much, and I am open to questions if you want to do questions, you have time. Thank you.
У кого-то есть вопросы к профессору Баллингеру?
Does somebody has question to Professor Bellinger?
And hopefully see you soon here. Теперь я хочу представить нашего следующего лектора, профессора Ад Бирк.
Now I want to present another lecturer, Professor Lartberg. He works in a National Center of Rare Diseases. This professor diagnoses more than 100 genomic diseases, and he has done research on drugs. One of the diseases this type he will tell you in his lecture. Professor Birk has double specialization. He is as pediatrician as genetics as well. He has done a first PhD in Weizmann in Israel, and the second one, postdoc, he has done in National Institutes of Health in the United States. It's one of the most important institutions on examination of healthcare system.
פרופסור בירק, אנחנו לא שומעים אותך.
Okay, now you can hear?
Yes, perfect.
Okay. So first of all, thank you for the invitation. My background is both medicine and research, and what I've done in the past 20 years as head of the Genetics Institute that is in charge of the southern part of Israel is to start and manage and expand greatly a screening program for genetic diseases in a very large Muslim community of southern Israel. So this is my team in the clinical part, this is my team at the research part. By the way, the person here is Marshall Nierenberg, who found the genetic code, visiting our lab. And a few words about the Muslim community in southern Israel. So there are many kids per family. 20% of the males have more than one wife. And most of the marriages are within the family, within a tribe. In fact, up to 60% marry their first cousins. And because of that, there are extremely many autosomal recessive diseases. Now, when I came in some 20 years ago, it was very hard to help in any way because the diseases were very specific. In fact, I'll tell you later that many of them turned out to be common throughout the Arab world, but you have first of all to find out what are the local diseases. You cannot check for 1,000 diseases in the world which are not relevant. Okay, you need to find out first of all what are the genetic diseases in your community, and then one can start doing the testing. The testing, there is the practical side of designing the test, and then there is the as hard part of community education, working with the community to convince them to do the testing. It means working with religious leaders. It's a Muslim community, so going by the rules of the religion, with the people of the religion. When we give lectures in high schools or in a college, usually a religious leader comes with us and also gives his sides of things, saying that yes, this should be done, which has great impact. And then once you have the results, one has to be able to give the proper genetic counseling, which means that one has to have a nice and effective genetic counseling network. And then what do you do next? So, for example, in our Muslim community, we reached an agreement with the local religious leaders. There are discussions where what age of the embryo is okay by the Muslim religion to stop a pregnancy, if at all, and we came to a consensus of 120 days, which allows us to do chorionic villi sampling. And then on the other side of things, we offer free pre-implantation genetic diagnosis in IVF, so that couples that do not want to have abortions can opt for that way. And so we offer possibilities for each and every couple, and of course the best is if couples get tested before they get married, and this can help them in making decisions. So the first step is to find the mutations in the community, and they are specific. Okay, in Israel we have a large Jewish community with mutations that are specific to various sub-communities of Jews, and in fact we discovered in my lab some of the main diseases in Jews also. But in the Bedouin community, in the Arab community, we found more than 50 new diseases that were not known in the world, besides finding more than 200 mutations in known genes. So one needs to do research first of all to know what you're testing for, and not take an off, just a marketed test which is not relevant. To do that, we set up a lab. My lab is the research lab, can do in a single lab the bioinformatics, the human genetics, but also the biochemistry. And we can do in the same lab CRISPR mice. We can generate mouse strain with the same mutation as the human mutation. We can do the same in zebrafish, and we can generate mutant Drosophila, so that when we find a mutation and it's a new disease, we need to prove that it is a new disease and that it's a true mutation, we can go the entire way. And in fact, we also do in the same lab stem cells from patients' skin cells. So all the options are there. It took quite a while to set up, but it works amazingly. This year alone, and I'll show you some pictures later, we've generated knock-in mice for 5 different new diseases. That's the last year alone. This is a partial list of the diseases, the new diseases that we found that were not in the textbook, not in the computer, not anywhere. And we keep finding new mutations and new diseases every month. Actually, for example, for cardiac defects, for tetralogy of Fallot, truncus arteriosus, we just found a single mutation which does a lot of these cases in a recessive form, in a promoter of a gene. Okay, and again, we had to prove that. We needed to generate mice with the mutation and to prove that we're right. So there's a lot of science to be done. It's excellent science, but it's also very practical and allows one to do the testing afterwards. This is just a glimpse of some of the bioinformatics tools we've generated, from ones for linkage analysis to finding disease genes. We mapped the community, which is important. You need to know your community genetically. And we mapped the subdivisions, in this case it was tribes, but of the community, so that we know that if we find a muscular dystrophy in one family, and then we find a muscular dystrophy in a totally different family, we know whether they're of the same origins or not, and whether it's likely to be the same founder mutation or not. A few examples. This is infantile neuroaxonal dystrophy. Okay, people are born fine. By the age of 1 year, they usually start even saying a word or two, and then by the age of 2 years, they are fully disconnected. There's total degeneration, and what you see is the picture. And we show that it is because of a defect in phospholipase A2. So it's actually phospholipids are formed in the brain and are taken apart by phospholipase. So if the phospholipase is not there, it's mutant, then it accumulates in the brain, the phospholipids, and the disease appears. This is another disease which we saw in many families. Okay, it's called arthrogryposis, or lethal congenital contracture syndrome. Just so I want you to see the pictures so you understand how severe are the diseases. Okay, this is a huge family tree, as you see, and in fact we had it in several families, large families. It was a very common thing, and we thought it would be a single founder mutation, but then it turned out to be several diseases, actually. So in several tribes, it was something in the phosphatidylinositol pathway. In other tribes, it was in a totally different pathway, molecular pathway, which is a tyrosine kinase. This is another disease, Birk-Barrel syndrome. You know probably of Prader-Willi and Angelman syndrome, that are genomic imprinting syndromes that are, it depends whether you inherit it from the father or from the mother, although it's not on an X chromosome. And we found another disease of that type, and again found the gene and the mutation, and we showed here in oocytes of Xenopus, of frogs, it's a potassium channel, and we could measure the electricity in oocytes of frogs, in which we inserted the RNA of the normal channel or the mutant one, and we saw proof that this is non-functional, and actually this mutation causes the disease. So we have mouse and Drosophila and zebrafish models for the diseases we study. I'll give you just a few pictures to convince you that we're doing this all the time. So these are zebrafish in which we inserted a mutation that we found for a new microcephaly, small head and intellectual disability syndrome, and we generated zebrafish with a mutation and their heads were clearly smaller. This is another microcephalic gene, another pathway, and here we used Drosophila, the fruit flies, and again we could show through the fly experiments that we're in the right gene. This is a new gene that we have not published yet for anophthalmia, for lack of eyeballs. And in fact, in humans, what you see is either anophthalmia or microphthalmia, small eyes, or coloboma, which is the smallest version of the defect. And in the various mice, you can see here one eye is fine, the other eye is missing, and in various mice, you actually get the different forms. So again, you start from a human disease, you find the disease gene, you find the mutation, you generate a mouse model for that to prove that, and then you're sure, because you're going to, based on that, screen many tens of thousands of people. And in the past 20 years I've been doing that, there was no single case that we were wrong, but that is because we're doing things the full right way. For those of you that know Ehlers-Danlos syndrome, which is a hyperextensibility syndrome, we found a new gene for that this year, and these are the mice with the gene. And you can, if you try to make such a tie in the tail of a normal mouse, you will not be able to. So the hyperflexibility is also in the mice. And this is an attention deficit hyperactivity disorder. We found a single gene that can cause ADHD, and we generated mice with this precise mutation in the mouse gene. And these are two mice, they're brothers, they're twins in fact, one is with a mutation, one without, and you can see, I think you can be convinced that there is hyperactivity in the one with the mutation. Of course, once we have the mice, we can study them, and in this case, for example, we could take out the brains, we grew neurons of the mutant mice in vitro, and actually we have, it's a Nature Communications paper of ours from last year, and you can learn a lot about ADHD through these mice. Okay, so what have we done with our Muslim community throughout the past, mostly throughout the last decade? So discovery of more than 50 new diseases, discovery of more than 200 new mutations, and some of them actually later on turned out to be common throughout the Arab world. So we make the discovery and then others start testing. For example, osteogenesis imperfecta, the fragile bone disease, okay, OI. In the world, it's because of collagen mutations, and it's a dominantly inherited disease. But in our community, no, it's recessive, and it's a totally different gene, and the mechanism is totally different. It's not a problem in osteoblasts, it's in osteoclasts, and so on and so forth. So one should understand that in communities in which there are cousin marriages and the marriages within the community, there are many genetic diseases. They're often hidden. People don't talk about it, and they can be prevented. And it's important to go ahead with that. So once we find the mutations, and actually nowadays, if we'll talk about how to go about new communities, maybe I'll talk a bit about that now. So one can actually do exome sequencing of not many. My guess would be around 200 to 300 people of a community, and from that screen in silico, screen by the data for known mutations in known genes. So for that, through that, one can already achieve quite a lot of knowledge what should be the screening in this community. And the other side of things is finding cases or diseases that are common in this community that are not known. That are, for example, many children are with intellectual disability, with mental retardation, with severe epilepsy, and the causes are not known. So if one takes these cases and finds the reasons either in known genes or if not going on with the research and finding the cause, then you get the other part of the screening that you can do, and from that point on one can do the screening. So in Israel, for example, we decided that screening should be done for diseases that are the carrier rate in the population is more than 1 out of 60. For example, 1 out of 10 is a carrier, 1 out of 40, and so on. Okay. Then it goes through a committee, and then it goes to the Ministry of Health that has to finance that, and they give okay. And every year, actually, we add more and more tests. So in the Muslim community in Israel, everyone is tested for SMA, for cystic fibrosis, for a panel of 18 common mutations, for Fragile X syndrome and Duchenne. Now, mind you, Fragile X syndrome and Duchenne muscular dystrophy are X-linked, so they are not recessive. It's not that you get it from the father and the mother. And here there's a problem because if you test people before marriage and the woman is a girl is found to be a carrier of Fragile X syndrome or Duchenne, meaning that she on her own transmits it, she might have problems getting married. And I'll talk about that in a minute, whether to do testing for X-linked diseases before marriage or not, and that's a discussion that every community should have. Then for the Muslim Arabs in Israel, we test for 99 mutations, but these are not just, we can test for 2,000 mutations. No, these are 99 mutations that are common in this community, okay? So they are, after a lot of work, and they're selected and they're effective, okay? And then per pay, so this is paid by the government, and if one wants to pay, one can get tested for a much larger panel, but most cases will be actually found in this smaller panel, which is free. Another question is whether to check the mother, the husband, and the wife. So we check the wives because this way we can check also for the X-linked disease, for the Fragile X and Duchenne muscular dystrophy. If the wife is not found to be a carrier, that's the end. If she is a carrier of a recessive disease, then we go on to test also the husband. So that's the way we do it. And then once this is done, we go on in the pregnancy and we offer free, paid by the government or the health services, either chorionic villi sampling, which can be done at weeks 11 on, so 11 until 13 usually, or amniocentesis, which is around 17. And then abortions, again, that's a very sensitive topic, and again, each community needs to think whichever way it goes. I'll give you 2 community decisions in Israel. So this is very Orthodox Jews that are completely against abortions, but they marry through matchmaking. So there's a matchmaker that meets the people and he makes the matches. And what they decided is actually that the testing is done for the young people before the matchmaking, and the matchmaker has the results. They don't even get the results. The matchmaker gets the results, and when he makes the matchmaking, he makes sure they're not both carriers of the same diseases. So that's one way, and they decided not to check for X-linked diseases so that girls that are carriers of X-linked diseases will not be in trouble. In the Bedouin, in the Arab Muslim community here, what we do is testing before pregnancies, and then we offer also during pregnancy, whenever the people want. So they come in, and they make their own decisions, and if they're found to be both carriers, they can either not marry or choose to do pre-implantation genetic diagnosis for free, or chorionic villi sampling and have an abortion if something goes wrong. So are we successful? Well, in the last a bit more than 5 years, infant mortality rates in this community went down from 17 out of 1,000 to 10 out of 1,000. So diseases are disappearing, okay? So we started by testing for a few diseases for each tribe, then we shifted to the 99 disease panel, which is expanded every year. And the testing is done in the community by Arab-speaking nurses, and that explain, again, you cannot generate enough genetic counselors to do the testing. So we're doing that by nurses that get a 1-week training, and then every few months they get another day of training, and they have access, they can always call a genetic counselor if they have questions. Okay, so that's the way the testing is done. It's done free, and we give lessons throughout the years in high schools, in colleges, in community centers. We meet religious leaders at least twice a year. We work together with the community, which is essential, otherwise it doesn't work. And many of the severe diseases are disappearing, so you get less and less of the diseases, which is great both for the families. It really changes the lives of the families, and for the financial health system, it's really important. And actually, both the testing and the chorionic villi sampling and even the PGD pay off financially extremely well, because they save the birth of really severe diseases that will cost the system a lot of money, besides being suffering for the patients and their families. And I'll end with just another side of things, which is treatments. So some treatments are emerging which are genetic treatments, and actually that's begun to be effective in the past 2-3 years. It's very costly, and one needs to negotiate with these companies how much, what's the pricing if one wants to do that. But there are many diseases that are genetic, and the treatment can be not genetic. Because of the genetic studies, you know what is the disease, what's the mechanism, and then you can arrange for a treatment that is based on that. And I'll give you one example. This is a family in which we found a limb-girdle muscular dystrophy, a muscle disease that starts here and goes down, and by the age, it begins at the age of 30. By the age of 50, they cannot move at all. If you put up the hand, it falls. They cannot breathe on their own, and in fact, they die by the age of 52, 53. And we showed that this is because of a mutation in a gene called HMGCR. Now, this encodes for an enzyme that makes something called mevalonate, or mevalonolactone. So we said, wait a minute, let's give the patients mevalonate. But there was a problem. Mevalonate is not sold, is not manufactured, is not made by any company. So one of my students worked for a year and synthesized mevalonate and purified and gave it to mice to just show that it's safe. And then we got approval, because some of the patients were dying, we got approval to give it. And this is after 4 months of treatment per os with this woman that could not move her arms at all. And in fact, now, a year and a half later, she doesn't need anything. She can breathe on her own, she can move, she can do practically anything. So we started with a genetic disease, and we ended up with treatment. And another side thing of this same story is that HMG-CoA reductase, the same enzyme, is the target of statins. Statins are the most commonly used drug to lower cholesterol. Now, in 20% of the users of statins, there is a muscle problem. And in fact, if they stop statins, usually it stops, but in about 1%, 2% out of the 200 million, even when they stop the statins, it goes on the muscle problems for months and years, and in a few thousands every year, it's a severe, very severe muscle disease with no solution. So we said, wait a minute, if our drug works on the genetic defect in this enzyme, probably it should work also when the same enzyme is inactivated by statins. So what we did is we gave mice a lot of statins. Usually a mouse holds on to the string very strongly. But if you give him statins, as you see on the left one, he falls off. But if we give a lot of statins and give our drug in the drinking water, as you see the mouse on the right, then the muscle problem from statins is gone. So you start with a genetic disease, you end up with a treatment for this genetic disease, and then this treatment is effective also in other diseases. So we're here for an interaction and a reason, and to do things right, one needs the entire scope, from research, which should begin in silico by doing exomes of the local population stratified into groups that you probably know best what are the groups within your community that are genetically of the same origins. Find in silico, and we have software that we designed in-house which is extremely effective in that, finding the mutations within the entire scope, not a single exome, 200, 300 exomes, we can scan that really quickly, find the common mutations, then in parallel start studying the diseases in this community and have a register of the diseases and discover new diseases or new mutations and add that to the panel. And then once you have a wide panel, which is locally represented, not what goes on in the United States or in Israel or in the Bahamas, what's going on in your community, then start using this panel. But this needs to be with an educational program in the community, in high schools, in universities, online, social media, and then train nurses for the testing, because people need to get an explanation. And then one needs to have enough genetic counselors, because suddenly you have a lot of genetic counseling to do. And then later on, tackle problems of initiating treatments. In our hands, it was very successful. It is very successful. And one should remember that more than 5% of the population have severe diseases. They might be mental retardation, they might be blindness, they might be all sorts of muscle or heart diseases, severe ones, many problems, okay? And the impact on the families is immense, and from financial point of view, it's probably by far the best investment one can make for a health system. And that's just one more disease we discovered. I just want to remind you of the severity of the diseases. This is a child who's 5 years old and cannot communicate, and he's fed. It's not that he's not fed. It's just that he cannot do anything with the food. That's it. I'm open to questions. Thank you.
Коллеги, если у кого-то есть вопросы к профессору, он будет готов принять вопросы. Если есть...
Colleagues, if you have questions to the professor you may address, I'd like to say that Professor Birk, for this time, unfortunately, he could not come to Tashkent. But Professor Birk will come to Tashkent if you have the patients with quite sophisticated, complicated cases where you actually had troubles in the diagnostics. Professor Birk will come and do it to help you without any pay. Please contact us, and we'll share your contact data, and you will be able to meet him. If you have questions, please.
Professor Birk, שאלה.
Very interesting presentation, Dr. Birk. And my question is about premarital screening for disease carrier status. So, as I've understood, in Israel, you first screen a female for carrier status, right?
Yes.
So this is something very concerning when we talk about carrier screening here in our country, because we already have such kind of program, SMA screening carrier, and the schedule is also to start from a female, but it could create some stigmatization. What I mean, when people know that some woman is a carrier, it could create situation then everybody would refuse to marry this woman. This is just coming out from mentality of our population. And did you have the same situation in your country, and how can we solve it?
Okay, so from your question, I understand that I'm very much at home. So we have exactly the same problems. What we do is actually we take blood from both. Okay, we take blood from both, and we test only the woman. Okay. First of all, if they're married, we take blood from both, and we test only the woman. And if she is carrier, then we test also the blood sample of the husband. And they always get one answer for both. You know, do you have a problem or not, as a couple? Okay, so we don't give the answer to the woman alone. We don't take the blood from the woman alone. To save money, we test only the sample of the wife, and if she's a carrier, then we test also the husband, because otherwise there's no need to test it. In premarital, so that's why for the X-linked diseases, we explain to them, and many choose not to test, and it's up to them. And then the main thing is that we really are very careful that the results are given only to the girl or the boy and his father, or usually it's his father or his parents, okay? And we tell them that they are the only one, and it is true, they are the only one that have the results. So the end of the day, when people want to get married, and I see it in my office or with the genetic counselors, very often, so usually the two families come together with the two, the boy and the girl that want to get married, and we tell them we will not tell you each one about what we found in the other. We will tell you whether you are fine. So the girl gets her results, the boy gets his results, and then they come and sit together with their families, and they get only is the combination okay or not. They don't get details when they're together. Okay, so actually, except for the girl herself and her family, no one knows. That's the way we solve it, and it works nicely. I must say that it is important in some cases that the team that works in the Genetics Institute is very clear that it is not allowed to give any information out. And sometimes we find it better that people from one community work in genetic services of another community, so that when they go home, they're not under pressure to reveal things, but they don't anyway. We just train them and explain to them, as it is in medicine anyway, but in genetics it's really far more important. Nothing goes out.
Okay.
Одну секунду. Professor, I want to clarify, because I think something was lost in the translation. То, что был задан вопрос, что делается, когда девушка, например, болеет.
So when we test the girls for genetic diseases, nobody wants to get married. In Israel, there is, and there will be the very severe laws about the personal data. You cannot see the girl. You cannot see the girl's method, the examinations, and anything. This way, when the people cannot, when people live in a community, nobody except for a girl knows that she's carrier, and the result is given to both of them, and they say
It's very important for us as professionals in the area of healthcare. We have to provide that information in the right way and explain. If a boy and girl, doesn't matter what kind of genetic disease that person has, you cannot say that they cannot get married. You can say that they have to undergo certain path, certain way that includes the use of different new technologies in the area of genetics. Since we actually, depending on the way how we provide that information to the patient, there will be reaction from the family. In Israel, another situation also exists. At the cabinet of the doctor, besides the patient and the plus one person cannot enter. For example, it can be the husband or the young woman herself. Parents cannot enter, uncles cannot enter. And if a young lady, she decides to pass that information, share that information with others, it's up to her. But in the patient, at the cabinet, only the patient can enter, and and the information cannot be shared. If the doctor does so, then doctor can be put into jail and sued. So that's why it's very important for us to explain. Because we said that genetics is a wonderful issue on one area, one time on the other it is a very difficult area. That's why for Uzbekistan it's very important to use it properly and avoid different types of misuse. So we are showing how it's conducted in Israel, and it's up to the Minister of Health of Uzbekistan how to actually conduct it in Uzbekistan, because they know much better the conditions related to local population in Uzbekistan. But in our case, we can provide assistance in Israel. We are using this method, and it is helping us to prevent different types of the divorces.
The main purpose of premarital screening is to explain to a couple that they have opportunity to choose some other spouse. Because if they marry, they could have genetically sick children, right? But as I understand, in your program, main purpose is just to explain them they could have special tests like PGD, CVS, etc., to have healthy children. And if we come out from first purpose, they can choose other spouse. What to do with X-linked diseases? Because in this case, anyway, a woman is a carrier, right?
Okay, so I mentioned X-linked diseases, and one option is not to test before marriage for X-linked diseases. That's one option. And that is what is usually done in premarital testing. And then after marriage, one can test, and if she's a carrier, then as a couple, they can choose to do chorionic villi sampling or PGD. Again, it's decisions that one needs to do within your community. You know, I gave examples in Israel how different communities deal with that in different ways and make different choices. So from my point of view, I think that before marriage, X-linked diseases should not be tested, and after marriage, yes.
Okay, very clear. Thanks a lot.
Я дам еще пример. I'll give them an example. We had a patient this week exactly with this situation. У нас на этой неделе был пациент.
We had the patient this week. There were two children. They died because of SMA. We conduct pagatum. They're gonna have children without this kind of problem. So that's it. That's how the problem is solved. Unfortunately, it's not free, but nevertheless, even if it's like paid service, but or whatever we do is actually relatively, say, affordable for the regular population. But certain times we do it still free. Someone was trying to ask a question in the back. I have a question. If the patient is smart, when we conduct PGT-M, the embryo heterozygotic or homozygotic dominant?
She asked if you make PGT-M for patients who have spinal myotrophy. Will the embryo be homozygous or heterozygous?
I couldn't hear the, I couldn't understand the question.
The question was, both patients have spinal myotrophy mutation, and they are going to do PGT. The question is, will they have embryos with, which are homozygous or heterozygous?
I can't hear. Maybe you want to.
Эмбрионы могут быть и гетерозиготными, и гомозиготными.
So the answer is embryo can be both heterozygote and homozygote. Some of the people will be heterozygote healthy and heterozygote healthy. First of all, we take homozygous healthy people, but the heterozygous people will be put in examination. Is there anyone else who would like to ask?
And hopefully see you soon in Tashkent.
Okay. Thank you very much. I'm leaving. Thank you for the invitation.
Мы переходим к следующей части нашей конференции, и мы с радостью хотим предоставить слово представителю.
We are going to next stage of our conference. We're giving a talk to a consultant of Urgent Health, Natasha Maximchuk. He will talk about the evolutions of NIPT.
Excellent, fantastic. Well, thank you so much everyone for being here. It's a complete honor and privilege to be speaking with you today. And I'd like to say thank you to our honored guests for attending, and thank you so much to the Israeli Medical Center, especially Dr. Yaron, for inviting me here to speak with you today. So my name is Natasha Maximchuk, and I am the sales manager covering EMEA, so Europe, Middle East, and Africa. and I work for a company called Your Gene Health, who is headquarters in the UK. So this afternoon, I'm planning to take maybe just around 30 minutes to discuss the evolution of invasive prenatal testing and explore the product range offered by Your Gene Health. May you please put my first slide up? That's not my presentation.
Альшер, это не та презентация.
So NIPT has revolutionized prenatal care by providing a non-invasive and accurate method for detecting genetic abnormalities in the developing fetus. So in this presentation, once the slides are put up, so we'll be looking at the historical development of NIPT, the highlights and the benefit it offers, and also explore the product range offered by Your Gene Health. So by the end of this presentation, my aim is to ensure that you would have gained a much better understanding of the importance of NIPT and why it's just so beneficial to a wide range of people, including the expectant mothers and parents. Thank you for your patience. Perfect. Spasibo. Okay, can you please forward it to the next slide? Oh, a clicker? Ah. Which one? That one. Ah. Okay, perfect. Spasibo. All right, so let's start with how the landscape currently looks with prenatal screening. So at present, prenatal screening is offered routinely to thousands of women each year as it's part of a standard antenatal care. So women identified as being at high risk of carrying an abnormal fetus is usually done via ultrasound examination and combined with blood tests. And then also we have the invasive screening of the chorionic villus sampling taking place roughly between 10 and 13 weeks gestation. And then we have the other invasive procedure, the amniocentesis, which takes place roughly between 14 and 20 weeks. And as many as 1 in 300 pregnancies have recognizable chromosomal abnormalities, which is why it is so important to be doing this kind of testing. And approximately 95% of the abnormalities seen, they are attributable to the aneuploidy of chromosomes 13, 18, 21, X or Y. So I thought we'd begin by looking at the evolution of prenatal screening. So essentially, back in the early 1970s, this is when the first amniocentesis procedures were first used on women. And then a little later on, the first ever chorionic villus sampling took place in 1983. So these invasive procedures have been used from the very start. And since then, it's been researched and developed that the movement really needed to shift from the invasive testing to a non-invasive testing procedure. And I will detail the reasons as to why a little bit on, in this presentation. So another major discovery along the way in the evolution of this prenatal testing was in 1997. This is huge. So this is when Dennis Lowe discovers that there is fetal DNA in maternal blood. And since then, it's kind of been a bit of a race between a lot of incredible researchers to really figure out and understand just how we can kind of test for all sorts of different genetic abnormalities. So in the early 2000s, blood tests and ultrasound images were combined to assess the likelihood of trisomy abnormalities. And then in 2011, we have the first cell-free DNA testing, which became available for sex determination. And then, last but not least, in 2015, good quality and fully validated CE-IVD NIPT testing becomes available to women all across the world. So, the NIPT testing was initially aimed at women who were at increased risk of aneuploid pregnancies, and these women were over the age of 35, or those who had prior a trisomy baby. But it's now recommended that this test should be available to all women. So why NIPT? So these are a few points that I really would love to stress to you today. So number one, it's non-invasive. Only a 10 milliliter blood sample is taken from the mother. NIPT is highly accurate, so it reduces the false positives and false negative results. Early detection. So expectant couples, mothers, hospitals, clinicians, doctors can find out as soon as possible into the pregnancy what exactly is going on with the health of the unborn fetus. The point over there, this is also huge. NIPT testing is safe to the unborn baby. There is absolutely no miscarriage risk whatsoever. Secondly, the test is really convenient. It's really time and cost efficient. So taking blood doesn't take too long at all, and the whole process is over relatively quickly. And then last but not least, NIPT is very comprehensive. So there's a broad clinical menu available, so mothers and expectant couples have the options to choose the exact kind of genetic abnormalities they'd like to test for. So, invasive screening methods. We have the amniocentesis on the left side, and we have the chorionic villus sampling on the right. So the amniocentesis is a very uncomfortable procedure. I'd say both of these are uncomfortable. And you're looking at a needle, which is very long, and that's inserted into the pregnant mother, and amniotic fluid is collected, and that is what's used to run the tests. The second, chorionic villus sampling, involves the insertion of a catheter, goes up directly through the vagina, through the cervix, round to the placenta, and scraping of cells is taken. And so when you're doing non-invasive testing, this is directly and very close to the unborn baby, and this is why it comes with various medical complications. And when you're kind of disturbing the environment that the baby is being developed in, it does come with a maximum of up to a 2% chance of miscarriage. So NIPT testing has been developed from the start in order to reduce the number of women having to go through the stress of having this test done. So the standard guidelines at present, an NIPT is recommended, and if there is a high chance of a trisomy or a genetic abnormality detected, that is when the mother will have to go through an invasive method. But if the NIPT test comes out as a low chance, you don't have to go through this invasive method here. So that's a huge benefit to expectant mothers. So earlier on in my presentation, I mentioned that blood samples were taken and that fetal DNA was discovered in maternal blood. So I've put a picture here to try and help explain what I'm talking about. So essentially during pregnancy, fetal DNA leaks into the maternal blood circulation. And the fetal DNA is shed as fragments and not as whole chromosomes. So the amount of circulating cell-free DNA from the placenta is also referred to the fetal fraction. And the fetal fraction continues to increase during pregnancy. So it starts off being very, very small, tiny amounts, which are undetectable, when you're first pregnant. But as soon as the 10-week mark hits, so when you're 10 weeks pregnant, there is enough fetal DNA within the blood sample taken to be able to analyze that material. So I mentioned earlier, when you're taking that kind of 10 milliliter of blood from the mother, 98% of that sample is maternal genomic material, like DNA. 98%. So it means only 2% of that sample taken is the fetal DNA, which is what you need to conduct all the tests on. Because it's the fetal DNA which is going to tell you exactly what is happening in the unborn baby. So, results and what you're kind of looking at. So this is a karyotype, and in humans, each cell normally consists of 23 pairs of chromosomes. 22 of these pairs are called autosomes, and they look exactly the same in males and females. And then the 23rd pair, just at the very bottom right there, those are the sex chromosomes, and they differ between males and females. And on the screen here, it's highlighting trisomy 13, trisomy 18, and trisomy 21, which effectively means instead of the normal 2 copies, we have 3. So that is what is flagged up when you're doing NIPT testing, is that the results will tell you whether or not there is an extra chromosome. And in some cases, some people don't have 2, they only have 1. So I thought I'd briefly touch upon the most common genetic abnormalities. As you can see here, we're going to be looking at Down syndrome, which is trisomy 21, and it's characterized by presence of the extra copy of chromosome 21 that we just kind of saw in the last slide. And this syndrome results in physical and cognitive developmental delays. And in the UK, 1 in 337 babies born in the UK has Down syndrome. And it's estimated that the incidence of the syndrome is between 1 in every 1,000 to 1,100 lives birthed worldwide. And there are a multiple range of medical conditions associated with Down syndrome. Edwards syndrome, also known as trisomy 18, is another genetic condition detectable by NIPT. And it's characterized by an extra copy of chromosome 18. And so this particular syndrome leads to severe developmental anomalies and multiple organ system problems. And last but not least, we have Patau syndrome. And this is characterized by an extra copy of chromosome 13. So these last 2 on the screen, these are very serious. So with Edwards syndrome, half of all babies born do not survive the first week of life. Only 8 to 10 of all infants will live past the first year. They'll only celebrate, well, their first birthday. Patau syndrome, 90% of all infants die within the first year of life. And so by using NIPT, it really helps give a wide range of people the results to make an informed decision whether or not extra treatment, counselling or guidance might be needed in those situations. So along with these three, NIPT is also capable of detecting sex chromosome abnormalities. So these are when there are abnormalities in the number of sex chromosomes, such as Turner syndrome, Jacobs syndrome, XXX, and Klinefelter. Turner syndrome is seen in 1 in 2,000 live female births. XXX syndrome is seen in 1 in 1,000 live female births, as well as Klinefelter syndrome. And last but not least, Jacobs syndrome is seen in 1 in 1,000 live male births. The physical outcomes of all these syndromes can vary greatly, with symptoms ranging from minimal developmental delays to really severe anomalies. So things like neurological malformations, organ failure, intestinal blockages, hearing and vision issues. So to help put it into perspective, what we're looking at here is a very long list of the various medical conditions which are associated with Down syndrome. Many babies with Down syndrome are born with cardiac complications. And another great thing about NIPT and the results that are obtained by expecting couples and mothers, it allows them to make the decision of perhaps changing the place or hospital of where they wanted to have their baby. So we are seeing a trend whereby if a mother is expecting a Downs baby, they can make the best decision to have their baby in a hospital whereby there might be gastrointestinal specialists on board, cardiac specialists. So once the baby is born, that baby can go have an operation in order to enhance the quality of his or her life. According to an American study conducted back in 2008 by Cherie Boulay, the medical costs of a child with Down syndrome from the age of 0 to 4 years old, compared with that of a child who does not have Down syndrome, effectively, the medical expenditures were up to 12 times higher. So parents will need to make informed decisions to prepare accordingly. Your Gene Health and the solutions that the company provides. So Your Gene Health was founded back in 2013 and has had quite a fruitful history in the past 10 years. I'm so proud to say that back in 2015, our company was the first to release into the market the first CE-IVD NIPT test. So we sell to customers in over 65 countries. We have around roughly 200 employees, and we have two parts of the business. We have one side which allows the company to sell the NIPT and the PCR solutions out into clinics and hospitals in various institutions so they can take that workflow in-house. And on the other side, we do have a genomic servicing company. So it means that for institutions who can't have the workflow taking place where the samples are collected, it means that the samples can be shipped directly to us in different offices across the world. So this afternoon, I thought I would introduce our NIPT solutions, but I'm going to focus on the top two. But effectively, we offer 4 different NIPT solutions to clients all over the world. And our workflows work with the Illumina NGS sequencers and the Thermo Fisher solutions, which are in the market. So when talking about the workflow, we have a couple of options. So it can be an automated workflow, and this means we have a very advanced robot who is able to conduct multiple steps of the workflow along the way. and this is recommended for the high throughput that we find in various different clinics and hospitals. So those institutions process over 1,000 samples. At the bottom here, we have the manual workflow, and these are for clients who are dealing with a much lower volume of patient samples. And so effectively, we have a number of steps. I don't have time to go into them in great detail, but effectively, we've tried to make it as simple as possible, and going through this very kind of methodical process and following all instruction will get you the results for NIPT. So I'd like to introduce our clinical menu to you all. So we have a very comprehensive menu, as you can see. We test for all the major trisomies, the fetal sex determination, sex chromosome aneuploidies. We've got rare optional aneuploidies, and we also now offer the clinically relevant microdeletions seen in this field, along with the Wolff-Hirschhorn syndrome as well. So what this means to expecting couples is that they can test for all of the most common syndromes which could potentially affect their child. And what we've come to find is that parents want to know all about the health of their unborn baby, and it's vital to understand what's going on in the development. So we do have a very large uptake for this selection of tests. And I have to say, it's been an absolute pleasure this week. So I'm very proud to be with my technical team. We've spent a lot of time at the Israeli Medical Center, and they have the most advanced system coming into Uzbekistan, and it's in the country right now. So that's very, very exciting news indeed. So our workflow overview only requires one single blood sample and can be taken at the earliest point. It can be at 10 weeks gestation. We have an extremely high and accurate detection rate, and there is a 0.2% chance of a redraw rate. And what this means is that mothers will only have to go into the clinics once to give a sample, because we know from our workflow and how we uniquely enrich the fetal DNA, is that that sample will be good enough for our systems to analyze and get all of the accurate data from that test. Our test is suitable for singleton or twin pregnancies, and we have a very fast turnaround time. So, for example, with the automated system, you can find out results in 3 days, because the last thing you want to do is completely stress out a couple who are desperate to know these results, and making them wait weeks and weeks. It's just not a nice story for them. So having the workflow in-house, in the country, will give expectant couples a much faster turnaround time, so they find out exactly what's going on. So I'd like to introduce to you the QS250. So back in 2020, Yourgene Health acquired a company called Coastal Genomics. They are located in Vancouver, so a long ways away. But effectively, they have designed brand new technology, which is revolutionary in NIPT testing. And what this instrument does is really focus down and pull out the fetal DNA, which is within that maternal blood sample. So you really need the most advanced technology to really drill down on that 2% that you get. So as I mentioned before, you have the 10 milliliter blood sample. 98% of that you don't want to test. You're testing for that 2% which belongs to the fetus. So effectively what we have is an automated gel electrophoresis machine, and it can do a multitude of things. It can do size selection, fragment length analysis, and fluorescence assay reading. And so if you look at the normal method of gel capillary electrophoresis, you put a current across an entire gel. Our machine is different. Our machine uses special cartridges, as you can see here on the screen, and each channel is individual to itself. And so what this means is that the instrument can synchronize and pass through a tailored current into each channel and synchronize the fetal DNA going through the agarose gel so that most of it, all of it, ends up in the sample collection part of the cartridge. So it means once this sample is collected, it can be easily put onto the NGS and you know that you are testing the fetal DNA. How is this achieved? So inside the instrument, we have a multitude of cameras and lights. Action, you press go, and then the computer is kind of programmed to analyze and through all sorts of bioinformatics. The computer will adjust all the currents going through the cartridge, really pulling down the fetal DNA. And this is a nice image of the different types of cartridges. So we've got 8 channels, we have 12, depending on the number of samples that you need to do. So this is a really exciting time for Uzbekistan because this technology has been implemented over the past 2 weeks. So the Israeli Medical Center now has access to this fantastic technology, and I'm so excited to see how far things go in Uzbekistan, and this testing is really going to change lives. So with the QS250, it's a very small instrument, so it doesn't take up too much space on the benchtop, so there's plenty of room for more if needed. Essentially, the way this machine is able to kind of detect the fetal DNA is that through our workflow, the fetal DNA is barcoded. So it helps because fetal DNA is different. It's much shorter than maternal DNA. So during the workflow, special kind of barcodes can be added, which means that the fetal DNA will fluoresce inside the instrument. And so that's how the instrument detects what it's looking at and can tell the difference between the fetal DNA and any potential other DNA which might be in there from the mother. So our PCR and electrophoresis portfolio, this comes into play once the NIPT testing has been done, and for mothers who have a high chance of a chromosomal abnormality in the baby, it means they have to go for the invasive test. The company offers a wide range of PCR tests. So starting from the very beginning, in conception, we have the male factor infertility test, along with the pregnancy loss. And pregnancy loss test is there to determine why a woman is miscarrying. The next phase is to go for the NIPT test that I've been talking about. And then we have the PCR, Q-star rapid aneuploidy analysis tests, the invasive ones. And then we also offer the newborn screening cystic fibrosis solutions as well. So our PCR test detects a total of 22 markers for chromosomes in a range of the chromosomes, sex chromosomes as well. I know this slide is very wordy. You don't need to worry too much, but if we're wanting to go into more detail later on during the conference about these tests, please do help yourself to all the flyers which are on the table outside the room, and I'll be more than happy to speak with you about them. I have a slide here which highlights the kind of benefits and features of our PCR tests. So it's a very straightforward method. You just add DNA, and it's a really simple PCR setup. And our products work on very common models such as the ABI 3500 and the Sex Studio. And it's only a 4-hour turnaround time. So again, it's a very fast test. I thought I'd focus a little bit on the male factor infertility. So around 10 to 15% of couples experience difficulties with conceiving, and Klinefelter syndrome is the most common cause of the reasons why. So our tests provide information to clinics and doctors and couples so that they can stop doing what they've been doing, which hasn't worked, and they can seek counselling and guidance so that they can actually have a successful pregnancy. Another really exciting test, which is up and coming across the world right now, which I'm delighted to say that IMC will have access to, is our DPYD test, and this slots into oncology testing. So new research, which has taken place over the world, has indicated that this test is essential when it comes to cancer treatment. So within the chemotherapy drug concoction, there is a chemical agent called 5-fluorouracil. And 5-fluorouracil should be processed by the DPYD gene in the body. And if you have a mutation in this gene, it means that you can't process the chemotherapy. It means that you'll have a very negative, toxic reaction leading to seizures. And 10% of all patients do have a reaction to chemotherapy. 1% of that 10% will die. So this test is needed because the last thing that you want to do is go for treatment to try and fight your cancer, but end up dying because of the agents in chemotherapy. So this slide here shows the clinical kind of pathway, the workflow. So I'll use myself as an example. So if I got diagnosed with breast cancer, stomach cancer, head or neck cancer, my blood sample would be analysed and checked for the DPYD gene blood mutation. And if I had a positive mutation, I'd go for a very reduced 5-fluorouracil treatment, or I'd seek an alternative like radiotherapy to try and fight my cancer. However, if I don't have a mutation, it means my body can process the 5-fluorouracil within the chemotherapy, and then I can continue on that treatment as a course without any risk of health implications for me. So, benefits of NIPT. This is what I want all of you to remember, please. It's non-invasive. Only 10 milliliters of blood is taken from the mother. It's very accurate, so reduces the false positives and false negatives, so you're getting very clear results. Early detection at 10 weeks. The sooner you find out what's happening with the fetus, the more time you have to prepare for the birth. It's safe to the baby. There is no miscarriage risk whatsoever. It's convenient, very time and cost effective, so it's very quick to take a blood sample. And then our clinical menu offers a very comprehensive screening and can test for multiple conditions. So in conclusion, early detection allows expectant parents and healthcare professionals to make informed decisions about the next steps in prenatal care, including further diagnostic testing or counselling. And detecting these conditions early in pregnancy enables proactive management and access to appropriate resources and support. And I'm absolutely delighted to tell you here today that we will be partnering with the Israeli Medical Center, so these tests will be distributed across Uzbekistan. Thank you. Spasiba, Ahmad, for your time and attention today.
Окей, если у кого-то есть вопросы, можно задать.
If somebody has questions, you can ask technical and practical questions as well.
Team up.
Здравствуйте.
Just stand at the bottom, just so we can answer questions together, and I'm happy to come down with you.
Я поняла, что у двойни можно делать НИПТ. У меня вопрос. Если...
I understand that we can do NIPT in infants, twin infants as well. What happens when when one of the fetus is dead? They can put on.
Can you? Yeah. So when there is a demised twin that is known, it is recommended to wait another 12 weeks for that fetus's circulating cell-free DNA to have passed, because it can affect the results. Yeah.
Basically, it's better to wait 12 more weeks before we do the NIPT.
Exactly.
Before the dead child
Yeah.
DNA to pass.
Yeah. Exactly.
То, что Дэнни говорит, это что в таких случаях лучше подождать еще 12 недель, пока ДНК погибшего ребенка выйдет из крови матери, и только после этого делать сам анализ. Он, к вашему вопросу, он не будет достоверным в таких случаях.
Хорошо. В одном случае
In one case, fetus may die in 8 weeks. You can wait until 12. But what if the fetus dies in 12 weeks? How many more should I wait?
Если срок поздний, как вы говорите, например, 18.
If the age is later, then you have to check other methods. Then IPT is not important.
Вы знаете, я хочу, чтобы все знали. Я все...
Обычно в таких случаях из-за оценки качества.
Usually in these cases, the quality, and due to the quality, the analysis won't pass. When we have the analysis of NIPT, their soft gets the analysis of sequencing quality. If the quality control will not pass by, then there will be a mosaicism. But in order to determine if you have mosaicism, you need to make an invasive test. Look, actually, in NIPT we always have result. We have only 2 cases when this result is absent. When the first case is when it's 10th week, but by fact it's 6th or 7th week, and the second result is in mosaicism. And in these cases, you can do invasive. If the pregnant woman has the mosaicism, pregnant people also can have mosaicism. Will you have answer? correct answer, or will that be incorrect, biased answer? It will be the same. Can I know the possible reasons of false positive or false negative tests? What are the result? What are the reasons? Well, actually, more than 1%, less than 1% of the mistakes are human-based disease. And the mistakes, it's like when you do the PCR incorrectly, or some reagents added incorrectly. I have one moment to add. I have gone through the data that was collected by many cases. In this analysis, the percentage of mistakes was 0.0038, and 1% was is just generalized, just for informed agreement. It's like when they say it's 99% clear, it doesn't mean that it's 1% mistakes. I am head of the genetics in Svetlana Andreevna. I am head of the genetics. The answers to all the questions, we have it in my talk, and about false positive cases, I will show in my case with the papers with different types of mosaicisms, like placental mosaicism with different types of cells, and in fetals, the fetus doesn't have this kind of cells. In these cases, yes, we have to make invasive diagnostics, which we cannot see the pathologies itself. The risk of this kind of event decreases by age. The more elder woman, the the less we have false positive tests. Because if you have pathology, then this pathology would go in meiosis, not in mitosis. In all elder women, the problem is with mitosis, not meiosis. The second moment, which can be very personal, when fading away twin. There were twins, and one of them stopped developing, and the second can be with a normal karyotype, but the fetus which had pathology and stopped developing, from his placenta, from his chorion DNA, the apoptotic cells can give a lot of DNA for women and pregnant. Just because the cells can go to apoptosis, and in this case we can get false positive tests. In my 11-year practice of reproductive genetics, I have worked with different firms. I had cases of false negative results when I wait for 8 weeks and 12 weeks. Patient has given the test in second trimester. The embryo stopped development in first trimester. It wasn't seen in ultrasound, but then anyways there was a chorion. There is a villi in a chorion which could give DNA for a long time. That might be one of the reasons of a false positive result. In this case, in these cases, you shouldn't do NIPT, or you can do the other types of examples. So the people say that NIPT is done by chromosome of a fetus, but it's not fetus of it's not even DNA of a fetus, but it's DNA of a chorion. Yes, it's called fetal circulating fraction or DNA. It's a little bit mistranslation. It's trophoblasts of a dermal formation. During the formation of an embryo, it can be like that the cells with pathology, like mosaicism, is a normal condition for a small embryo, right? In a first, second, fifth day of development, when embryo gets corrections of cell pathology, it eliminates it and it goes to apoptosis, or it goes to trophectoderma oblast cells. So in general, there is a type of a mosaicism when inside there is no pathology because of the embryo can be corrected, and it goes to trophectoderm, and placenta will develop from this one, and we can see the pathology, and it can be false positive nipped because it's truly a placental mosaicism. I'm so sorry, the last question. And if the relevance is 0.038, can we stop the pregnancy? No, it's not going to be correct. If we get the correct positive result, we have to confirm this result with amniocentesis. So it's not villi, it's not placenta. We need cells of fetus who are in amniotic fluid, or it's cortiosynthesis, but cortiosynthesis has higher risk of loss. It's 4% of a baby loss, but amniocentesis has 5.5%. It's not that scary that it is so shown there. It's 0.2%, and thank you very much.
Здравствуйте.
Good afternoon, dear colleagues. My name is Andrei Gavliev. I am on my education background. I'm a specialist in molecular genetics. I defended my thesis on that, and I work at the Albert Einstein College of Medicine in New York, and in that specialty. And now I work at Israel Medical Center in Tashkent. I wanted to talk to you about the existing technologies that exist in the world, and which ones we have chosen to introduce here in Uzbekistan, and why we have done so, and why specifically we have chosen those. So, there are genetical diseases that exist in the world. They can be divided into large groups, chromosome anomalies that affect the chromosomes, or large fragments, or the genetic diseases that affect single genes. And these two types require two different approaches to them, and but in both cases we can prevent any of them. So, talking about genetic diseases, most of the time, in that case, we're talking about recessive inheritances, and where we have one copy of gene with a mutation does not bring to disease, and both parents can be healthy. And for that particular reason, this kind of diseases can actually be detected in the families where they did not ever have children with such diseases. In order to get this kind of disease, you need two copies of mutated genes. In such families, you can have a totally healthy child be born without mutation, or you can have children with one copy of normal gene, and another one with a mutation that can bring into disease. Or you can actually get a child two copies of mutations. One was inherited by a mother, another one from father. In such cases, we have children with actually a genetic disease that cannot be cured. As Dr. Yaron has put it, we are working with a family who have 2 children who have died from the spinal muscular atrophies. So I told you already that this kind of diseases can be prevented successfully. It's not only the theoretical opportunity, it was already shown in practice using the success diseases as a spinal muscular atrophy. It can brings to the fatal cases in children under the age of 4. So unlike spinal muscular atrophies, it cannot be cured at all. So it affects the nervous system, and it was kind of prevailing among the Ashkenaz Jew communities. Well, I'm saying it used to be because that was eliminated as well as a disease in Israel, as well as among Ashkenaz Jew communities in U.S. There was such a person named Joseph Epstein who, in his family, 4 children has died because of diseases. The child would be born with such an incurable disease and would die, and parents would actually bring another child to deliver another child, but situation would repeat. So that person has devoted own life in order to prevent that such a kind of things would not happen in other families. He established an organization called Dor Shalim. We are preventing the tears in interpretation. So the only goal the organization was pursuing to prevent that disease or the fatal cases among children because of that disease. So this is a website of that organization, and they are saying here that they are safeguarding the health of the future generations. This is their mission, if they put it. So this disease can be identified using the screening, genetic screening in this case. So you can conduct an examination of future parents and come up with a conclusion if they have the gene with mutation. If both of them they have, then in that case you know that there is a risk that a child with such a disease would be born. Such screening, thanks to the efforts of this organization, including as well as other non-governmental organizations and accompanied by the Ministry of Health, became actually quite common in the territory of those countries where everyone basically would undergo this examination. So further, if a patient or future couple they have such a mutation, what kind of options they have? They can, first of all, this choosing a right partner when a couple where a person who doesn't have such a mutation. So the next one is pre-implantation testing. If you find a person with such a testing, you can get echo, you can get a child from the tube to use embryos from the lab conditions and test those embryos and identify which ones are healthy without carrying that mutation, and they can actually plant it or seed it. So only in the families, even in the families where both parents have the mutation, you can get still healthy children be born without using the abortion. Or if the pregnancy was started, and then only after that it was identified that the embryo has 2 copies of gene with mutation, then in that case we have a prenatal testing with abortion. It could be one of the last resort measures. Thanks to the efforts on the elimination of that disease in Israel back in 2003, only 1 case was registered. In 2004, none of such diseases registered. This is a Times newspaper of Israel, which provides information on that case, and saying that the efforts and initiative that was put by that organization helped to wipe out that disease. And just like that, humanity can actually eliminate any other types of the genetic diseases. From technical point, we have everything that's needed for that purpose. majority of the genetic disease can be eliminated from the natural so you have the vaccination, and here if you conduct similar approach in terms of being organized and testing, and over the course of the life of one generation you can fully get rid of from the majority of diseases. The scheme is testing is conducted. After that, when you have
detected that the risk of having a child with a disease, you do PGTM. It's a pre-genetic testing for monogenic diseases. As a result, you will have children who are not carriers of these diseases. And in Israel Medical Center, now we are doing this test, my screen, which helps to determine mutations in more than 500 tests, and it can get more than 1500 tests at the same time. We can say that this kind of big panels, including fully genome sequencing, it can give away the question of stigmatization. We had testing of the patients of couples who are in relativity. One of them had 5 mutations, the other has 2, and one of them was for both of them. As the diseases become more and more developed, we can make more screenings, and we can understand that every person has 1 or 2 people, and if mutation has everyone, then there is no stigmatization. But this is the question of enlarging the screening methodologies and enlightening the population. As I understand, the question of stigmatization would go to the past. It would be something like common knowledge that no matter how healthy people are, there are a couple of mutations, and there are healthy people we have because we're getting married with people who have different mutations. That's why this is the reason why the people who have close relationships, they go with genetic diseases. So if the couple is relatives, there's bigger possibility of having the same type of mutations within them. So let's go back to genetic mutations. The second group is chromosome anomalies. So it's syndrome Down, Patau, and Edwards. They start from normal place. As a rule, they come up from people who are not carriers of chromosome abnormalities in most of the cases. Here you can see the situation when during deletion of sex cells there was an abnormality. So from the parents there is 1 more extra chromosome. So the embryo of these people will have trisomy, Down syndrome. What can we do in this case if we cannot prevent this screening of parents? There is a screening of a first trimester. It of course very useful, and it helps to determine most of the chromosome abnormalities, but it's not absolutely accurate. First of all, most of the patients who are referred to invasive diagnostics, they are being sent there just to have safe line, and 1/3 still misses the trisomies. In order to solve the problem of accuracy of prenatal screening, we have admitted NIPT. So now we will talk about it. It was also talked very detailed today. So today we decided to to implement NIPT in our clinic in Uzbekistan, and we started to choose from existing the world practice options. Which criteria we use? We used the data of manufacturers, but we weren't based on that because it's not independent source of information. We have learned technical advantages if there are some screening which by its design is thought and done better than other, and we have looked for independent results of a screening, and also independent researchers which we had after widespread of this screening. Let's look at each of these points. We have chosen screening from Eugene Health, and because it's firstly it allows to enrich the fetal fraction. Here you can see the fetal fraction determination among 10th and 15th weeks of pregnancy, where the non-invasive testing can be available. And you can see that in most of the cases we can see from 5 to 10% of fetal fractions. In most of the non-invasive prenatal tests, all the DNA from the blood is extracted and sequenced, and then with the usage of bioinformatic algorithms, they determine what is a fetal fraction. We will be interested in 5% or 10%, which carry the important information. Eugene Health has the know-how. We can do the automatic electrophoresis with cleaning of a fetal fraction that previous lecturer have talked about, because they have before the element was distracted from cell, it goes through electrophoresis and cuts off the part which corresponds to fetal DNA, and as a result we have done 2 cycles of tests of last 1.5 weeks, and whatever we see, the fetal fraction did not go down from 15%. We had 15-18% of fetal fractions. It was much better starting position to start the qualitative analysis when you have not 5% but you have 15 or 20% of DNA, fetal DNA. It gives more clear answers. And sequencing is done in Illumina platform, which is best at this time, and best checked at this time. So furthermore, where do we get the information of reliability of this test? Well, we have the site PubMed. There are 30 million of scientific publications. This is the site of National Institutes of Health of United States. So they have the better works of the whole world, from Western Europe, from China, from Japan. Whatever publication goes through the world, it goes to this list if it's if this is published in a good referred scientific journal. If so, we have done a test of Iona test, and we can see. You can do this test yourself. You can go to the site and you can read 58 scientific articles that you can read. And what regarding the validation, it has gone through independent researchers from London to Oxford, Manchester, Leicester, and Leeds, and a lot of things which were from Great Britain. And this data is not from the manufacturer. This is tests from the user, and it comes from countries where they use this test. After having the test, they publish the results. And at this relevantly, the size samples that they has gone through as a validation. They have very simple result. The detection rate was 100%. When we talk about the mistakes, they occur during 50,000 or 100,000 samples. So when there were 437 samples, the efficacy was 100%. So then we have looked through the data when tests started using widely. What could we see? This is an article which used in a difficult case when it was used for analysis of twins, and the author showed that for Down syndrome the accuracy practically is not different from monoploidy. For Edwards and Patau it's a little bit lower, but this test is still most accurate non-invasive method of this kind of pregnancy. Furthermore, we like this test by a quality of doing and the feedbacks from World Scientific Medical Committee, and unfortunately it's not very cheap, and we have been offered well, the cheapest tests, saying that our test is not worse. We checked these tests are not worse, but they are sometimes better. But we, before making decision on choosing of a test of a Eugene Health, we have learned about this alternative. We didn't see any better design of studies. They didn't use the Illumina. They did not use Illumina, but it was a Chinese sequenator where there was no data. We didn't get results of validation in the site of a company which sell this cheaper test. They cite the data by other NIPTs. If they say NIPT, the accuracy goes more than 99%, and we haven't found any independent researchers. And we did not want to say no to decrease the price, but anyways we try to learn for the feedbacks. When you do not have the data, the medical data, then the patient feedbacks can be some sort of independent information on test and the first test was very impressive for me. I will tell you very short. At the age of 38, woman did non-invasive test in 12 months. It was all good, and they told that they have a good girl. Everything is fine. The time comes for next ultrasound, and they say, you have done NIPS, then you know that you have a healthy man, healthy boy. And the woman is shocked. She makes comparison, and in 30 weeks they go to the same non-invasive test again on 34th week, when there's a lot of fetal DNA in blood, 24%. They say that you have woman, and she morally prepared that she has a baby with pathology with sex chromosomes, because this kind of a difference can mean that they have different syndrome, with a different amount of sex chromosome. After there was a healthy boy, in 2 months we had a karyotype. Yes, the baby was a normal uh, person with a normal karyotype. Any test can have mistakes. None of the tests have zero mistakes, but here two mistakes was done in small short period of time in one patient. The second feedback was about people have gone through this test, and after the amount, the test is not passed, and a test did not go, and we did not do it for free, but you can pay it and do the test again. What does it mean? For a specialist who knows the economic of this kind of tests, they know that high rate of this kind of failures. If you have two unsuccessful tests for 1,000, you can do it for free for a patient to keep your reputation. So, but you have 2 out of 10. If the fifth test does not go, you cannot redo it for free. It would increase your price, and it would disappear the competitive competitive disorder, and then they cannot do it. Say, we cannot do it the test for free. This is kind of sign that it says that test cannot be done for free. And the third was positive, but they had the result, and it got confirmed. I know it's not representative, it's not 30%, but much higher, but that's the only independent information that we had about this test, and we decided not to implement it, of course. We have to say that the advantages of NIPT goes up if NIPT is the same with that correlates the amniocentesis, but not the screening of first trimester. There is no fatigue problems and no risk of spontaneous stoppage of healthy pregnancy, and because and all of it makes sense when NIPT works on a very good level. So, answering the question, why should I pay more? The high quality NIPT, it's comparable with amniocentesis, but it's much cheaper than amniocentesis, and in this case we do the economy. So in non-high quality NIPT, you shouldn't compare it with amniocentesis, but you can compare it with screening of a first trimester. If the test does not give us high rate of assurance in our result, then why should you do it? You can just economize your money, and you can do traditional screening of a first trimester. And why do we do all the stages of NIPT in our clinics in Uzbekistan, in Tashkent, in Darkhan region? It has advantages for a country and advantages for a people. The advantage for a country, the specialist training, the process of training is shown here. NIPT is done by our head of the laboratory, Iroda Khan Ziaudinovna, and there is the technician from the manufacturer company. And after finishing of these 2 weeks, by online support of the manufacturers, Iroda will do this test by herself, and this is training specialists here and making working here. working place here. If you send this test outside, then the working space would be created somewhere in China or in Great Britain, not here, and increasing the budget and publication of Uzbek specialists in international scientific examples. This is the example of this kind of examples as a result of previous tests of genetic testing, and we can see that the same head of the laboratory is one of the co-authors, and the authors of these publications are the doctors and scientists and specialists from Uzbekistan. None of the countries, none of the scientists are from other countries, and it was published of a pre-informative genetic company, and this work is very interesting to get accepted for a publication and doing it outside, and this work is done here in Uzbekistan. Regarding pluses, advantages for patients, the analysis is done in Uzbekistan. The same control, quality control in every stages of NIPT, from blood sample collection till giving the tests are controlled. There is no risk degradation of samples during transportation. It increases the specificity and the lower risk of getting blood samples again about the transportation, and of course this higher speed of doing the analysis. As I said, last 2 weeks we have done it twice, NIPS, and so we are implementing the technology which can prevent both gene and chromosome abnormalities. For one, we can use MyScreen. It's NGS based carriers of screening, and the other is used for NIPT. Thank you very much for your attention. I would love to answer your questions.
Есть вопросы?
Do we have any questions? Yes, please. Dear Alexei, thank you for a talk. I have a question for you and the previous lecturer as well. You have talked about microdeletion syndromes, primarily something's wrong. Exactly, with the syndrome of Angelman and Prodravil. In most of the cases, it's imprinting syndromes from the same period disomies. Can we do this kind of detections with these tests? We can do a lot of microdeletion syndromes which have been talked of the previous talk. If we can go back to that slide and we can determine them during the deep sequencing when we can work with 12 samples, not more. Yes, we do. We do detect the Angelman syndrome with the help of. Can I translate the?
Uzbekistan? Oh,
No, no, it's worldwide known that
Yeah.
Angelman and Prader-Willi syndrome are imprinting syndromes, which means a child is sick because it gets only 2 copies of one parent of, let's say, 15th chromosome. Non-microdeletion or microduplication, 2 same copies of one chromosome from one parent. This is the reason of the disease, and can we detect this type of the disease with
Yes,
this
the tests do detect those 2 conditions that you specified. Cindy, do you have anything to add to that? But I think what could be interesting, if I write down your question, and maybe we can discuss this kind of together afterwards, so I can kind of really understand the question, because at the moment, are you speaking about other different types of conditions with a similar...
Yes, it is a different type of condition. There is no microdeletion or duplication. There are 2 copies, and they considered like normal ones, but they have the same sequence. 2 chromosomes have the same sequence. Maybe Svetlana could answer.
Этот тест тестирует на микро...
This test is test for microdeletions. If you have microdeletions, we can determine it. If you do not have this kind of things, then 2 copies of one chromosome, it's not done in this test. Yes. Yes, in syndromes of Prader-Willi and Angelman, there are a couple of reasons. Some microdeletions. You can determine the test of microdeletions in higher levels. You cannot get parental disomy by this method. That's other methods, chromosomal microtubular analysis and screening of parental disomy. There is no reason. It's look, if we have whole genome sequencing with a lower, if you can do this soft to find in these genes. Yes, you can do postnatal or perinatal, but we're talking about fetal fraction. You shouldn't by fetal fraction we cannot get so deep of reading in this process of point mutations or heterozygous. For this, so we need different methods. You have to understand NIPT is a screening method. It means like microdeletions is determined with this kind of things was a syndrome, Down syndrome. It's not 99%. Even for deletions, you don't have this kind of accuracy that we would like to have. If the parental disomy, we can add some other things, the accuracy will be less. Now monogenic tests are being researched, but we cannot get very good confirmation of what we have found. PV and NPV of these methods cannot be found. NIPT is a chromosomal abnormalities when deletions with special cases in chromosomal anomalies, of course, in 99% Down syndrome. The other anomalies have less specificity and less agreement. Yes, thank you very much. All understood. Thank you very much. Hello, everyone. Thank you for a very interesting conference. Dear colleague Babur, yes, we are asking for a specific test, knowing the pathology of this family. We're not doing a screening methodology. We're doing a specific test for family. When we are doing screening, we are going to a screening whatever we can screening. But if we know uh, the family history, then we ask for specific tests. Thank you. Thank you very much, Alina Yakovna. This is the difference between laboratory things between laboratory people and doctors. You know, we understand that screening is a screening. Thank you. Thank you very much, Andrei Pouch, for your interesting talk. Thank you for discussion. That's why this conference is good for us. For me, it's an honor to get head head of the conferences, medical genetics chair teacher, Svetlana Andreevna Dvechik, please. Thank you for invitation. Hello, dear colleagues. I'm very happy to see doctors genetics. I'm very happy to see the specialists who want to do everything much more quality way for a patients, for their patients. My talk is modern genetic methods in prenatal diagnostics. Let's meet. My name is Svetlana Dvechik. I am head of the genetical department in Israeli Medical Center. I work with patients and I work with quality questions in genetic laboratories. My background is 11 years of working in genetic children with the consultation of Fomin clinics. There are 20 clinics of ECO and expert prenatal diagnostics on invasion in the basis of chair of prenatal diagnostics, Medvedev. In genetic laboratory of medical genomics, I got big experience of analysis of interpretations of NIPT and pre-implantational genetic examinations. I have 11,000 tests I have gone through, and that's why I was invited to Israeli Medical Center. For this, I show my biggest appreciation to Yuri Vladimirovich. The life is like a box of chocolate boxes. You don't know what's inside. This is I cited Forrest Gump of a naive person with genetic disorder. To speak the truth, it's characterizes great of perinatal diagnostics. We don't know what's inside. So when and how we have the pregnancy, we can get the surprises, but some moments we can find out with the usage of genetics. What is the frequency of inborn development? 25-28% of the children they are healthy, and 3-5% are babies with defects. It's chromosome abnormalities, it's genetic factors. They talk about Victoria Winova about prenatal diagnostics. In short, it's prenatal diagnostics and ultrasound of expert level with We do the invasive diagnostics for confirming or getting rid of chromosomal abnormalities in a fetus. Let's see how it works. The same like Professor Nikolaidis tells that 28% of people with Down syndrome we work with a high quality. If we go to Cochrane and look at the sensitivity and specificity in different countries, we see 71% or 60-something% because the detection of risk groups in chromosome abnormalities depended on very many nuances. Andrei have seen it, I've shown it in Russia when we had a pilot project on a first screening. We calculated how it works. It shows that 70% of women do the invasive diagnostics just for nothing, and we still miss 20% of people, and they are born without any markers of a chromosome abnormalities. If we include NIPT, does anyone in auditorium hear the English translation? Please raise your hand so that I wouldn't continue speaking to the void. No? No one is hearing? Okay. What are the methods of chromosome abnormalities? NIPT is non-cellular DNA. This is screening test, not diagnostics. It means you can have false positive and false negative results, and these tests have biological reasons. It's not only incorrect transporting and diagnostics, it's invasive prenatal diagnostics. We have to get either amniocentetic fluid or chorion's villi when we see the morphology of a chromosome, but it may require the cultivation of cells. Not all centers can cultivate amniocytes, and not all of them things do the disomy. So this is the level of diagnostics, not screening. The prenatal diagnostics is non-invasive. Prenatal test, the screening test, it's not correct to say diagnostics. At this point, the development of genetics, it's done for all 24 cases of a chromosome plus microdeletions. But if we decrease the amount of chromosomes, we start seeing microdeletions and monogeneous diseases. We have tests for monogeneous diseases, but their accuracy is not high, and it doesn't allow us to go to a clinical practice very easy. Regarding where we have DNA from. We can show it here. So this is the amniotic fluid is closed. It doesn't go to the DNA goes from placenta, from chorion. So the circulating DNA, the fetal, is in a pregnant woman. This is its DNA comes from here. In the blood there is inner cell DNAs, and there are outer cell DNAs. It's like from a mother and mother. And it all analyzes by NIPT. And whatever we talked, our colleagues. It can be not only the false result, but it can be sign of patients that have tumor. Also, there might be a mosaicism in a patient. It decreases the price and it decreases the time, but anyways we have to start from something. You have to not to send the money to different countries, but say to give the uh, very modern technologies and to develop it. As the matter of development of this technology, the dates will decrease. The analysis is done with from 10th weeks of pregnancy. From 10th is better because from the 10th week and there would be enough fetal fractions, and so that we can do the analysis on a high quality. It corresponds for one uploads and two uploads pregnancies. No biochemical screening is done, and it is good for pregnancy of a woman with donor cells. It's not done in Uzbekistan, but what I think is the technologies of BRT can be done in the world, and it can go to practice. For pregnancy, it goes for us as well.
Что выявляет НИПТ? Трисомия 21, 18, 13, аномалии.
So the anomalies by sex chromosomes, the trisomies are very rare, and by all chromosomes, we have monosomies. So why should we do that? This is rare cases. It's usually frozen pregnancies or abortions, but no, it's not that way. People with other chromosome anomalies can be born too. I will show you in a moment. But there is a moment when we determine the status of our placenta. When we have placenta status in these kind of people, we can bring to malfunction of placenta, which can bring to fetal-placental malformation. And if you see that by NIPT there is a chromosomal abnormalities, even if it's not it's not determined by other tests, then we have to make sure that they wouldn't have preeclampsies and eclampsies, so that we will not have death of a fetus in a third trimester. Aspirin examination is we don't know about it. Probably it's not gonna help, but anyways we should try because we don't have other known methodologies and techniques. If there are anomalies in a placenta and fetus, then the patient is in a risk group of losing a fetus in the later stages of pregnancy. And there are list of microdeletions for validated tests where the correspondence of test evaluations are high. What are the ways of having analysis? You take the blood from a pregnant, then you extract the DNA, and then you do the library quality. You take the exons which correspond for this kind of Illumina test so that it can read. Then the next one is there is a step enriching the libraries. When we can see the results of this device, I was very happy as a clinician because I worked in a laboratory where we included the analysis by ourselves. We had analysis not from United States, we had it from China, and it's very happy to see that not 2, 3, 4% of a fetal fractions, but 15-20% of a fetal fractions. It can be acquired by this equipment which I dreamed of. It makes enrichment of fetal fractions, and this is the difference of this NIPT. And for a clinician it's very important because we can trust this test which has a lot of fractions of fetal fractions. By my experience I can say, of course by the data analysis of the mistakes which are connected to a sex or chromosomes with the results of a NIPT, when there are too many samples in this company, then there is a small sample of fetal fraction, so they don't have enough capacity to get the anomalies. We had these problems. We had these problems in Russia in state centers when we had this NIPT fractions like 10 years ago, and these negative results were conducted in conferences to tell about the false negative or false positive results. We have two strategies of NIPT. First strategy of NIPT, I have done it in a previous workplace, all these in these clinics of expert prenatal diagnosis. We have done it screening all the pregnant women who has in our the place. They do 10 weeks of a pregnancy. We don't know what is the biochemistry, what is the ultrasound, so there are no calculated the risk evidence in any program. So it's a whole big program. That's the first strategy. And the second strategy is risk stratification. It's more economically feasible. It's to get the groups of pregnant people where NIPT is more addressed. And in this group, people who have more Down syndromes, women older 35, men older than 49. About the last data, we had a big research published. The age of the woman the age of the men was not 35 or 40, it was 50. And the anamnesis, the anamnesis echo and other chromosome anomalies in a family history. In these cases, we administer NIPT as other biochemical screening. There is a gray zone. It's called differently. By Uzbekistan, the risk is 1 to 100. That's a high risk. For this kind of people, they need to be abreast to better screening methods. In some places, I have seen 1 to 60. This kind of numbers, and if risk is minor or middle, 1 to 1,000, 1 to 2,000, then in this mild group we can advise NIPT. A lot of countries have gone through this way, and they have given funds for the groups of mild risk, because we prevented having babies with pathologies, because even in this group we will be catching a lot of Down syndrome kids, and in this group of gray risk, we do the if we address them to a NIPT, we decrease the number of unnecessary invasive procedures. If you plan biochemical screening in a normal placenta factor of growth, then in reality, in 5% of kids with the Down syndromes, they had one biochemical deviation. So in these patients also needs to be paid attention. I had a history. That patient had low PP, and she had Down syndrome. She had very low risk, and she have sued us, and during the law procedure we determined why and what and how we did. So we can stop these kind of things. If a mother has Shershevsky-Turner syndrome or mosaic form of Shershevsky-Turner or mosaic trisomies, then the calculations, risk calculations by sex chromosomes can work incorrectly. We can have risk of a false positive, or we can miss the pathology. So this group of patients, we have amniocentesis or biopsy of choreo. You do not do it more than less than 20 weeks of age, and for autosomal anomalies for all chromosomes, we can do during the twins. Anomalies of sex chromosomes we cannot do in twins, because the risk calculation programs cannot work very efficiently if there's two fetus. We can only determine about the sex, if we have Y chromosome or no. If we have Y chromosome, we can say that at least one of them is a boy or both are boys. It's not clinically validated to determine the mosaicism. Yes, we talked that the mosaicism can be found that the quality control has not passed, and by some chromosomes there is no answer. We have answer for 18th, 13th, and the sex chromosomes that are low risk, but Down syndrome does not have an answer. So this kind of events can go to amniocentesis. For this kind of people, we can do karyotyping and FISH methodology for this kind of cases. The main thing is the test must be validated. So for some chromosome anomalies that does not show the other mistakes, the test is not validated. That's why we do not know how it works statistically. If we find by ultrasound what kind of markers we have, what things we have, their patients will be under the risk, and for these patients we offer invasive perinatal diagnostics. If this patient by ultrasound goes under the risk, we recommend them to have a diagnostic examination. We're not giving the second type of screening. We're not giving them NIPT. We're going to a diagnostics. If a patient writes informant request, then we can offer NIPT. What other disadvantages? If she had cancer, or if she had bone marrow transplantation, if a woman have ovarian cancer, then these patients have I haven't talked about the vanishing twin. This is also disadvantage of a method, because if the pregnancy um, twins, then one of the fetuses have stopped in development. We can get false positive result of the NIPT, because the amount of a fetal fraction in because in fetal fraction you can have DNA of a dead fetus, because the cells of another fetus would go to apoptosis, and the DNA go to circulation, because that's why we can get a false positive by sex, or we can have other negative false positive results. So we can wait not for 8 weeks, we can wait for 12 weeks. But we had a history, we had waited for more than 8 weeks, then it was still remained as a boy. What other moments can we have? We can have, if BMI is more than 30, in this case we have a risk of low fetal fraction, and not to get the result. But we got the tests where we have enrichment of fetal fractions, especially fetal fractions, because that's why this type of a test we can have in this type of patients. But if it didn't happen, then we will have to wait for 3 more weeks and then do it again. Why in a woman with a higher body mass index they cannot have NIPT, or they can have negative results on a low fetal results? Because fatty tissues, adipocytes, they also go to blood, and they get distracted, and they also have free circulating DNA, and so there would be a DNA of a woman, of a fetus, and of adipocyte DNA. So by correspondence, it can be less the fetal fraction, and also fetal fraction can be less in patients who have heparin in anamnesis. So before we advised to give the tests of a heparin before the examination. If they does the injection at 9, and then we advise them to go to take a test, and then to have the heparin injection. About microdeletion. NIPT is done by microdeletion, but we have examination of PPV. We have all the we have so many results of amniocentesis. By data of result, it's about 9%, about 10%. In my practice, in 10 years of work, I have the same. But now technology has developed so much. Now we have more accuracy of microdeletions. But anyways, you have to inform the patients that if patient has a positive result, it can be not determined by amniocentesis. It's more reluctant to a Down syndrome. So in microdeletions, you cannot look at it in a big scale, because we will have false pathways to amniocentesis, how it happened with my patients. So, and that's very important to look at the list of microdeletions which were validated for this manufacturer. If we compare different technologies of NIPT, if we use whole genome sequencing methodology, then we can have all the options in our arsenal, and some periods can be absent in different technologies. I don't want to talk about it a lot. About the recommendations. Recommendations change. Before we used to say to patients that we have NIPT for all chromosomes, but only for 3 chromosomes. It was recommended by the whole world. It's chromosomes 21, 22, and 18. In 2023, ASMG is main organizations of genetics. They included sex chromosomes into their recommendations, and syndrome of DiGeorge. So this syndrome has been worked through so in a high quality that it was included. Of course, not for all 24 chromosomes. It can stay as an option, but it doesn't go to as a recommendations. So in syndrome of DiGeorge, it's official recommendations. NIPT for all the chromosomes, it goes like an option. We can recommend to all the patients, but it shouldn't be that reliable, right? Actually, there were different examinations and examinations of NIPT efficacy during microdeletions. Here, it's in the DiGeorge syndrome. It showed very high efficacy, and in other types of examinations, we had lower results. So, in other cases, we can have more false positive and a lot of amniocentesis. So psychologically and financially, it's not very effective. What about the rare the chromosomes 16, 8, 9? They all go to premature abortions, but they can go to a birth too. 8, 9th also there were some of the we have information by a 16th chromosome. My patient have stopped the pregnancy in the end of the 2nd trimester. It was a long distance when the pregnancy was continued. It didn't stop in an earlier period. And the second moment, why do we have to do that? It's not only for a pregnancy, it's just to understand that there is no placenta pathology. The types of mosaicism, this kind of book, which should be a table book for all the genetics. I love Harner. I don't know how people can work without it. This kind of a photo. This is a classical type of mosaicism. The types of the types of fetus and placenta, fetus placenta relationships, and how the mosaicism happens. And the pathology is restricted by just fetus and by partially of a fetus. It can cause fetoplacental abnormalities, but sometimes no. It can have different data. We can talk about it with a genetic doctor, talking about possible negative impacts. I have a lot of information based on that. This is algorithm of PGT with a professor from Kiev. We have collected it, and we have collected it with from different recommendations. PGT is recommended on 24th chromosome. After that, about NIPT I have finished. About the invasive procedures, I would go very fast. Which diagnostic possibilities we have in modern prenatal diagnostics? We have gone through the karyotyping, then we used chips, and then we came to a full sequencing of an exome and genome. Now I use in my practice full exome sequencing. How we get genome of a fetus? It's full sequencing of genome or whole exon sequencing or targeted methods. There is an official recommendations that chromosomal microuterine analysis is recommended to have anomalies if you have it in a ultrasound, and in absence of anomaly we should do karyotypes, because you can have the mutations which do not have a clinical prevalence. In Israel, my very good acquaintance, Elena Basel, a professor, she shared with the experience of using prenatal exomes. Now it's in Israel very actively used, and they are not giving the options with unknown clinical options. And for different group of patients, they can offer, they can inform about the test, but they can discuss what is the percentage of determination, what is the feasibility. Now these moments are very important and depend on proper counseling. Chromosome micromatrix analysis, HMA. In some of the chromosomes that does not exist in any recommendations. There is a karyotyping as all type of recommendations, because you need to cultivate them, or you can see uncultivated chorionic cells, but you can miss the mosaicism. So mosaicism can be done by a short-term and long-term cultivation both together, and it gives 26% of accuracy about getting the pathology. So now it's recommended as a first-line examination if you find that the abnormalities in ultrasound. The diagnostic feasibility is 36%. It's not 2%, which we talked before. If you divide by percentages, it's 50% AD and others, and 35% diagnostic value for trio exome. So trio is not compulsory to do prenatally, because addition to that is only 3%. How to consult patients if we have multiple structural anomalies, especially skeleton anomalies and heart defects. We determine the pathologies of full zone sequencing, and if we increase the TVP, it's 3.2%. It's lower than detection of chromosome anomalies. And during the fetal abortion analysis, it's 35%. We can do it in any material without giving emphasis on a material. This is my talk on the entry last year. This is family from Israel. It's Jewish skinneus mutation with a syndrome of Smith-Lenny-Opitz, which have been found perinatally, and it's not a chromosome mutation, which can be found only during the sequencing of exomes. And this family had 3 loss in family, and there are forms where there is very severe malformations of development, and the frozen pregnancy in early pregnancy period can have monogeneous roots. And this is we had very hard heart disease and polydactyly. I said it's possibly Barth-Bigley syndrome, and now we took, and yes, it was a relative of a Barth and Bigley syndrome, and by amniotic fluid we can find this kind of diseases and risk groups earlier. So modern genetic methods allow to increase the determination of prenatal genetic pathology and to find the relevant risks, and you can affect for the further reproductive stages, but not all these methodologies are used as a routine based, because technical material is not always available, and at this period in Uzbekistan, technically it can be available and it can be materially. The more analysis we make, and the better and the faster and the cheaper it becomes. Thank you very much. I would love to answer your questions.
Хорошо, обязательно. За такой интересный доклад.
Thank you for an interesting talk. We are representatives of Republican Screening Centers. We are very delighted to see you. First question is how relevant the NIPT and during the echo. The relevance is the same as if it was a natural pregnancy or extracorporeal pregnancy. So there's no need to use different algorithms to calculate, because we use NGS, so it deletes all the questions. What about fetoplacental malfunction in a pregnant woman? Can we do NIPT in these patients, because we cannot use biochemistry in that? Yes, we can, and it will not have the negative effects in the results. And if the pregnant woman is gystogens, it's definitely it doesn't affect. It was researched. Only heparin can affect. Thank you very much for your answer. Thank you. Antonina Olekovna, one more question.
Спасибо большое за обновленную информацию, но на этой конференции.
Thank you very much for new information. It's mosaicism, because we have very many mosaicism, because there are very many translocational problems of mosaicism. The second question is if a patient has, if a baby has an imbalanced translocation, and if one of the parents has balanced translocation, let's say pregnant woman, or how can she have the NIPT if she didn't know? No, she knew about it. We know that their family, that they have the chromosomes of Down syndrome, and parents diagnosed, and mother is carrier of triplody, and is there a risk of for the fetus? So should we offer them NIPT for them or not? Yeah. Okay, you shouldn't offer them. Okay, I got it. What about translocational abnormalities, unbalanced ones? Does NIPT detect? So if there is the extra 21st chromosome, which is adheres to 18th, NIPT will determine the higher risk of Down, but it's not validated for this kind of a methods, because it's very slow determined. If you allow me, I will add it. If mother has the translocation, it's the best method is PGT. It's extracorporeal pregnancy with PGT. So PGT will give any other examinations, including the balance one. It's then it's detected that's by the same method as we're using with PGT-M Can I have a small example from my experience? We usually, when we diagnose classical trisomies with Down syndrome, we just think that this is out of order, then that there is no risk to try to examine parents. But we had a case with trisomy of a classical Down syndrome, and we said, okay, it's just coincidence, the risk is very low, but anyways, come to prenatal diagnostics. The second pregnancy was unsuccessful. It was undeveloping fetus, and then family acquired to us. We have sent the parents to karyotyping. It shows out that the mother is a carrier of balanced chromosomal translocations, and translocations has been done from the second to third chromosome. Now this woman is pregnant. She first trimester. When I was giving recommendations, we have to take into consideration the invasive prenatal diagnostics in planning of each pregnancy. Now she is pregnant again, and she has given a screening of a first trimester that we are preparing the family to prepare that for a diagnostics. But all the cases of anomalies, even if it's karyotype, and they need a karyotyping of appearance. Yes, I agree. Any cases must be karyotypized by appearance. Yes. Why? There is considered that there is an intrachromosomal effect. For example, there is something between autosomal translocations. The risk of chromosomal abnormalities are higher in other chromosomes as well, because the translocated chromosomes, they can disturb the meiosis, and this and these locuses, they can have a deletion focus to other places as well. I haven't seen these kind of exams on mice, but it's possibly the other concomitant pathology. A lot of people talk about it. Possibly it exists. Thank you very much. One more, please, Dr. Genetics.
Спасибо большое.
Thank you very much for a talk. It's very interesting. It's technical question. The whole sequenced genome and whole sequenced exon. How many days do we get the answer? Like days or weeks?
Это же инвазивный метод, правильно?
This is invasive methodology, right? Do we have it in 2 weeks? 2 months? In general, it depends on volume of patients. If we cannot give it in 2 weeks, we just not take the analysis. Up to now, the periods are very long for Uzbekistan. If it's exon specific, it can do it tomorrow. But we need to have 12 patients. If we do not have 12 patients, well, then we can say we are sorry so much. We cannot do it in adequate time frames for these patients. Okay, I got it. So this is the kind of history that will be developing. But this method can be done invasively by amniocentesis. What is the minimal date? It's like 14 weeks. Our cytogenetics, they say that there is not enough material. That's why they say that the material is not enough. 16. Yes, we have the 16 too. I just wanted to know your opinion. Inaudible for translation.
Если нет больше вопросов, да, тогда...
If we do not have other questions, then thank you.
Спасибо большое.
Thank you very much, Svetlana Andreevna, for your very interesting talk. We're inviting the next speaker. It's a doctor of ultrasound diagnostics, genetic, licensed specialist for FMF, and Victoria Buinova, to stitute in short. First prenatal screening, that's the name of the talk.
Здравствуйте, уважаемые коллеги. Приветствую вас на этой замечательной конференции.
Thank you very much. I'm very glad to be here. I would like to thank you for inviting me. It's a great honor for me to be here. When I look at the program, I was thinking why my speech is my presentation at the end, because usually we talk about prenatal screening. It's usually but perhaps my last slide will provide answer. My name is Victoria Buinova. I am a doctor, gynecology obstetrician, and first specialist in doctor genetics. When I used to be at the prenatal diagnostics, I heard genetics, and I was thinking that they are talking the Martian language. So some things were kind of familiar sounding, but and the other words could not get. Then finally, I just decided like. So I'm from Ukraine. I'm more than 1 year. I live and work in Uzbekistan. Perhaps my mentors can introduce me more. This is psychologist from London, and Braunstein is also my mentor. Because I also conducted my internship in Haifa and another. Those are my professors, my mentors, who taught me the systematic approach and details, and not chase the downs. So I would like to explain the cases. This first case is 39 years old. It's a third actually pregnancy, and the first abortion was when the person was young. And on the ultrasound, on the first we have a 1 in 3 as is the thickness of that space and the marker of the syndrome of the fetus. And that's a Ukrainian story. We're talking about aborting the pregnancy. Over the course of the last year, I witnessed it. I came to the conclusion we have a lot of similarities. It was suggested to conduct the screening of the first trimester. So we have to get a high level risk, but it was quite a low obstetrician risk, because the screening was conducted on a platform algorithm taking into consideration perinatal access. The Nonivasive procedure was suggested, and the patients had actually have chosen the centers. So it was conducted on the 17th week, and so quite a normal karyotype. Also, the microarray was suggested, but financially it was not possible. So then this actually the antibody was conducted with on further management of the pregnancy, and as a result we had a healthy child, a son and a boy. So that was a ultrasound detection of the other markers on the first screening, and besides the remaining ones, and besides, so we have actually such a wonderful boy and the trimester. And now we have actually the 5 years old boy, already named Bogdan. Second case, the 6 years old, nipped on the 7th week, was a low risk of the main chromosomal pathologies. In the first screening, and the pivot was TVP 3 and 8, and the anatomy and everything was correct. What was recommended? They can suggest it was also suggested to actually discontinue the abort pregnancy. What should be done? Should we can combine a screen? Of course, yes, because we always, all of us understand that when we have such extension and such this diapason of the space, we're going to have 80% of fetus being absolutely normal. Only around 20% we're going to have the pathology, including the cordial anomalies in around more than 200 varieties that can be eliminated. Of course, and screening, we have to use it in any case in consultation from genetics, of course, and invasive procedure. What kind of invasive procedure we should use in such a situation? NIPT, we already have it, of the amniocentesis, because of hormone biopsy, because it's also the repeating the NIPS. And we have conducted amniocentesis and also the diagnostics of the current or micro NGS cryo, and in this situation it was correct. This pregnancy was carried until the end without any anomalies. So case 3, so the 2 years old, first pregnancy, to 12 to 13 weeks without visualization of the nose bones. That was also, we conducted a combined screening and recommended NIPT when it's possible. So talking about the financial possibilities, so this first screening was a low risk, also taking into consideration absence of the visualization of the nose bones and the xenophobia. In the latest stages we have found it, and we have the quite healthy child being born. Next case, last one, 22 years old, first pregnancy, first screening on the ultrasound anatomical norms, but on the biochemistry it's a quite low MOMS and a quite a high level of the indicator on the 21. And so all the actually the bleeding that was taken into special care. So quite high level of the invasive diagnostics, but the risks were extremely high. What should be done next? And the second trimester, on the 21st week, we have sported the placenta of megaly. The anatomy of the fetus was normal. At the 20th week, this actually the abortion risks were passed, and invasive diagnostics were conducted in the 21st week. So accordingly, the placenta of the biopsy was conducted in line with accompanied by amniocentesis. The amniocentesis was quite normal. Female curative 28th week was under the supervision, close supervision, and cesarean section, and the child was born at 560 grams. And as the child survived, Alisa, so the two-way cataracts, but all of other diseases were avoided by her. The parents actually very much wanted to have this child being born. The pregnancy was not aborted, but nature wanted to abort it, because from the very beginning there was a lot of bleeding. Why I'm talking about this? Because we are talking about the high technologies and NGS and others, but even now we're making mistakes in the very quite simple things. So most of the cases, there's a lot of them.
We're not taking when I talk us, I'm talking about the medical community. We're not doing prenatal community, and we do not use the systems of algorithms. What they have wrote, what they have done, and sometimes we do the different methods, like a family. When we go through Down syndrome, and we go through the color procedures, but anyways, we talk about to the patients with the markers and the things, but abortion of pregnancy is without telling the risks, without the diagnosis. We are taking too much of examinations. So Antonina Alekovna said, if there is one case in a family of a prenatal of a person, we need to caryatipize the people. We need to caryatipy because unfortunately there would be relapses, and there will be dramatic, and it goes of specific changes, and the amount of microchip transistors to using the different machines using ultrasound, but the screening detection is not at the same level. We do not we cannot catch up with changing the apparatuses what we have, and therefore we need to use the other methodologies which can be used the Down syndrome people. We use it for a long time. First, prenatal screening, all all three things must be very important. The perinatal are on a basis of a lot of sciences. It's obstetrics and gynecology, reproductology, embryology, genetics, biology, neonatology, the pediatric surgery, including cardio surgery, pediatrics, and so on. This kind of jokes we have fetus when you need to know all these deviations of science in perinatal diagnostics. Talking about the screenings. What is screening? Screening, in if you translate it liberally, it's like screen. So there are criteria. For example, everything that goes through the pores, and everything that doesn't go through the pores, it's a preliminary things, and everything that goes, you should go by. It's the higher risks of a diabetes, the higher risks of a Down syndrome. This is all the risk stratification, and this is not diagnostics. But the plus is that you do not have big volume of material things used, and less invasive procedures. And when we talk about the first thing talk about the topic, perinatal diagnostics have changed. The first pyramid is the pyramid of 23rd year, 23 of last century. The main thing was when it was giving a birth, or when the ultrasound came, you can see if it's boy or girl. Now it's shift. When 12th month, we have to do so many things to find out that by which criteria it comes. When we talk about the first, it's a prenatal screening. We understand somehow chromosome, genetic, and inborn diseases. But gynecologists, OBGYNs know that it's not only that one. It's preeclampsia, gestational diabetes. It's not welling up. It's intrafetal thromboembolism, it's isoimmunization, thyroid dysfunction, deficits, and symptomless bacteriuria. It's so that's why it's combined tests. When we talk about we determine only 2% of structural anomalies, which are developed to 60 in all groups, and 6% of aneuploidies by the talks of other talks. So these 2% are all the doctors of ultrasound examinations. When they do the examinations, they find it out. There's a resource we call EuroCat. It's European database which give information to European regions about determination of European regions. How can we summarize it? Both in inborn anomalies and others as well. For example, all the anomalies, they are given in 33 regions. and the termination rate is 27-68%. It depends on the country, it depends on the clinics, it depends on a doctor himself. So we have to learn and learn. If we talk about Down syndrome, then the determination is European 33 regions. It's from 30 to 93%. It's screening detections, which we talked about the previous lecturers. So the main quality for them, it's spina bifida and the Down syndrome. In Down syndrome, Ukraine is also given here in a pre-last condition, and there's a percentage is very low. And of course, due to development of technologies, we have a different approach. Sometimes, even 100 years ago, even in 70s, it's what's considered that most of the Down syndrome is patients up to 35 years, but usually it is found in patients more than 35. But the amount of person after 35, and all of it was concentrated in this group in the 35 years. We all know that there's a tendency for late pregnancies, so it was 20%, and 50% of all the cases of a Down syndrome come to this group, and this group needs very high observation and high quality testing. If we come back to the history in 2 words, then sometime when it was found out that chromosomal coming out and the connection with the ages, the women with 35 plus, they had invasive methods without having ultrasound. It was the nervous cord defects also affect the chromosome abnormalities in second or third trimesters. It was HGG, it was a beta HGG, then Pepe added. Then we learned how to find neuromas, and then the last of last century, it was opened the color substance where the perinatal diagnostics step changed, and the test was combined, and we used both markers and maximal combined tests of first trimester screening. And in the beginning of 2000s, we had nipped. And then we said, hey, why is it so complicated? It's 99%. Let's take away all the ultrasound specialists. So we take them away, and we have very special text. We used to say it NIP diagnostics, but it wasn't so easy. When the screening is, if we make a first correct combined test, look at how many factors are used as factors. These are the formula. Individual risks. It says the age of the mother, then VRTs and other things. Ultrasound examinations. If the people come on time, then it's what time, and this center use what kind of analysis and what the there was results, and based on the national laws. And we look at these all tests which have all these years. If we have gone through the whole world places, then the most effective was combined tests. The less tests is like family organism. It includes not only the chromosomes, but testing Why should we run after these tests? Why can't we should do some NIPT first? And I agree with that. Even schoolboy understands in this table. If we compare to 99 to 95, then 99 is better than 95. Then why not? Why not? Why shouldn't we do this non-invasive perinatal test, which is logical? But it's not that easy. If we say that we compare advantages and disadvantages of a combined test of a NIP tests, then the combined tests are not cheap, are not expensive. It was determined by time. So there's spectrums and other disadvantages. So they depend on things, and all these scheme it should be organized. These organizational moments are national priority. In this case, NIPT has higher case of specificity. We get better results than in combined tests. In 10th month, they come with the NIPT and then come with results and taken into consideration. Then we do other screens like anatomic scans and blah blah blah. Of course, they take into our non-invasiveness. We do it here. It's expensive. It doesn't correspond to screening, so we're not firing the ultrasound doctors. And invasive diagnostics, it's diagnostics with exactness of 100%. It's more expensive, and this is very timely analysis. In invasiveness, losing is 0.1, 0.2, and we do some tests. For example, if we have higher color space and we do the better tests, then we have not full spectrum of analysis, and chromosome abnormalities would be much better, and we can use microtubular analysis. And in this case, we will use I really like the analysis of Katie Billard. It is a specialist of fetus from Netherlands, who talked about this. If she said if I had NIPT, then so many thousands of people wouldn't cry due to invasiveness of, but I would never learn to do the invasive methods. So she found her pluses too. We are people, practical people. We have to rely on national protocols, and if they don't have it, we can look at the international, we can adopt them, and we can use them here. What international protocols say? SSU.org have renewed the guidelines of a first screening, and now it looks like basal and detailed, depending on targets that we are looking for. If you're talking about diagnostics, then we are talking about the details. And our Uzbekistan orders for neonatal screening, it's written very good. It says that the ultrasound we have to do from 11th to 13th weeks, which correspond to international protocols. The main thing is not the weeks, it's millimeters. For combined screening, it's 4584. The earlier we do it, the precise we have for chromosomals of chromosome anomalies due to biochemistry. The later, the more exact we can do the anatomical diseases and abnormalities. The logic is like this one. If we have nipped more specific tests in chromosome anomalies, then we can do ultrasound later. In Israel, it's 15th week. So correspondingly, our protocol have written it very good. They told that it's recommended to send to gonadotropin of a human and other people. For fetus aneuploidy, we can advise them to have NIPS on 10th week of pregnancy. So in national protocols, it has been written of very clearly, so we can recommend it for all pregnant people for having the better, clear picture of overall things. And it's very important, the point when they keep forgetting, and I have it every day. You shouldn't recommend for pregnant women after in second trimester, especially when they have nipped. The sensitivity of this method is 60% only for the first type of women who haven't done it in a first trimester. It's the repetition of the same. So making a resume of an algorithm of our observation, taking into consideration that we have all the modern technologies by international and national protocols, the algorithm of having a normal pregnancy, having ultrasound in a normal the normal anatomy of TVP is less than 3.5 millimeters. Invasive and non-invasive tests, it's depending on the characteristics. We do not do it all the time unless the woman pays for it. So you should recommend and explain the risks and of course recommend them this type of examinations. The anomalies more than less than 3.5 millimeters, then it's genetical consultation. And by our consultations is 1 to 100. I don't understand where the 1 to 360 comes from. If we have international recommendations, we had 3 strategies in different countries. Different countries went to by different strategies. A lot of countries went to different countries, nipped on exchange of ultrasound. And some people left the routine screening of a first trimester in, and then they included NIPT as corresponding in this group, and some people added NIPT taking into consideration just the age, and others by ultrasound. Most of the countries got the middle algorithm. More than 180,000 people women got through this method. The high risk is 1 in 10. The intermediate risk is 1 in 1,000. 11 in 1,000, pardon, and the low risk is less than 1 to 1,000. So intermediate risk it was targeted NIPT was advised for this kind of people. If the negative test, then it's just active collaboration. So it's not me.
Сейчас вернут слайды. Помня продолжение своей презентации, оговорюсь, так как...
Remembering of our presentations, I will tell that there was a reproductive medical center. So we are talking about extracorporeal pregnancy. Does the IVF affect on is there a difference in diagnostics of IVF and a natural birth? Of course, all three questions are no. So when we have we talk about
Those that conducted such contacts will shall undergo NIPT. In general, everything is similar, just like in case of spontaneous pregnancies. Invasive prenatal testing is just recommended in such three algorithms that we have talked about. So this for increasing the accuracy and the sensitivity about 35, and after the pregnancy after echo. Those are the actual the recommendations. This is actually the speech of Oliver Kagan. It says that NIPT is very good, but we have to think about the pre-test consultations for identifying the possible causes in order for preventing those in the first place. We have to understand that this NIPT is actually the highly sensible on the validated pathologies. There's no NIPT without Uzi ultrasound. If in order not to do NIPT in the small ones, in order to do NIPT on the still pregnancies, and we have to have the ultrasound and understand what is there, and say it's a twin, and if it's like what's the rate of expected survival. So they have to conduct it. We have to think, remember of the small fatal fractions, and that's what we can do in the sampleless weeks. If the NIPT is positive, then we can do some further diagnosis, because the NIPT is a screening, it's not diagnostics. You know, to conduct the testing the defects of the fetus chromosomes, and quite rare chromosomes abnormalities. We have to conduct this, and of this T on the obesity. This takes all of the nuances into actually the account. Of course, the NIPT is not for selection of the gender. Saying this, we conduct in 10 weeks, and we're going to have it like in 1 week, and we can stop the pregnancy. So that should be regulated at the national level. And in my view, in such conclusions, I would say that I would actually indicate the gender in those kind of results, if there is even a pathology. Talking about this, it's the first combined test, or the screening, as you used to call it. It's not only the assessing of this chromosomal anomalies and as well of the fetus, it's evaluation of the prenatal obstetrician risks. So it is very important, specifically including after the pregnancies, because this is the top of the iceberg. Talking about anomalies and
we can come to this period later, until we run for trisomies and the color process. So we can put the markers in prenatal risks. Usually it's preeclampsia, it's pre-birth conditions. It's if it means each 5th or 6th pregnancy. So if we come to this kind of a place, our protocol national correlates to the English-British protocol, where we determine the risk factors and how many and it gives frontal diagnostics, taking into consideration the pulse index and so on. We do not agree with the for the patients of a high risk. I am for doing it when a patient of all risks. It doesn't increase the costs by this formula, but in this case, 30% of first people who would never go to risk, which that's why this kind of screening by my view and by view of very many national protocols, they should be done in many things. We increased the determination of these people by twice by giving them aspirin. We foreseen the risks of preeclampsia 60% to 30% in the second trimester correspondingly. So. By using aspirin 150 milligrams at night until 36 weeks, it's also written in our national protocol. But unfortunately, not everybody reads them. Coming back to this table, first prenatal screening, it's first trimester when we have to evaluate everything. Look, we're here. OBGYN everywhere. That's why we cannot say it's not mine, this one is yours, and I just refer it to you. It's not gonna work that way, because as a OBGYN I have to determine both left side and the right side as prenatal diagnostics. We all know Albert Einstein very well. Each housewife or a schoolboy knows this, knows it. But the theory is when everything is known, but nothing works. But anyone who has never made a mistake has never tried something new. So now we have something new which is developed and it's developing. So it's something new. We should not create something new. Somebody has done it already for us. So we have to take away all the extra that we have from post-Soviet medicine and use this new one. And these conclusions I want to make is the topic today is non-invasive prenatal testing and the possibility of genetic diagnostics. Anyways, regarding of all of the things that we achieved, this goes in a first basis in a first trimester. NIPT showed a greater decrease of false positive results, and the possibilities of broad NIPT should not be ignored. But anyways, we shouldn't ignore the ethical moments which I said before. And before doing the NIPT, the consultation is must-have. So hopefully in some times NIPT can be done in shells, and but before that we should do all the ethical problems that we have it. So thank you very much for your attention. On this I am finishing up my presentation. I would allow myself to finish it up. I have the corresponding surname. If you have any questions, please. Thank you very much for your very interesting talk, Victoria. I'm very happy to see you. I wanted to meet you for a long time ago. In 2007, I, with my director, Sharipov, Malina Karimova, professor, have gone through the city Donetsk in 2007. And the Kypros came to certify you all. And we have been there with the biggest enlightenment, and at that time, and we were very happy for your achievements and the proposals. And today, when I looked at your slides, and that's 3.5, and that you send them to abortion, I was a little bit angry at Ukraine. One case was from Ukraine, and the three others were Ukrainian. So, and this it's then it's very sad. We couldn't have it in my country because we have biochemical screening. If you worked for a if you work here for a year, then what basis of getting your in Uzbekistan? So 4584. But it was in 2014. It was worked in 45, 40, 57. Because that's why risk is not good if we get Kippers and Nikolais. It's just for a note. Thank you for a song. It was so nice. Thank you very much. Thank you for a comment. In this situation, the national protocols are much higher than a national protocol, the international protocols. I talked about it, but the problem is, we can talk about. Sometimes we can talk, about our centers where we work. I'm talking about the centers I'm talking about 7 clinics where we worked, where we implemented the national normatives and whatever we use here, and that we have our result. And the result is none of the what pathologists have missed. Um, I can say about the same centers like leading centers like yours. When we talk about the centers of regions, it happens both in our center and in your center too. We cannot go to any ways. We have to learn and learn and learn. And you cannot imagine how many years we have waited. We are waiting for it from 2014. Yeah, the high quality NIPT is here. That's what we're talking about. Thank you. Thank you very much. I I hear it all. Of course, it's very good that we have done this kind of a conference, that you're lobbying modern technologies. But now, sitting here from Ministry of Health, I would like to say that in order to have more successful promotion of these technologies, we have two problems which are in different universes. These are all the representatives from the regions. They have to make conclusions from themselves. This universe connects on us. Early, we have problems in the first trimester. Why? The second trimester is much more because they go to registry later after 14th week. Well, what can we talk about it? Of course, they go to biochemistry of second trimesters, and the percentage of missed cases are so much, and it all misses by time. But time is very expensive. That's why we have to finish the prenatal diagnostics of until 22nd week. Any prenatal diagnostics have to be finished until 22nd week. We have very big opinion hopes on a document, that regulatory document that is about to be admitted, where we would have early registration of pregnant people. And the second one is not in a University of Medicine, but it's also in our society. If we want to go to prophylactics of monogenic diseases, it's depending on relative marriages. We have to start very big work on family planning, not spontaneous pregnancies, not desire or undesire, as we said before, but the program of family planning. Then the things that my screen, my NIP, they would have more effective points to develop. So many specialists who sit here, and if everybody who sits on their places, if they will lobby it, we will start it a little bit farther. I want to go a little bit further. I want to appreciate the organizers for us, for organizers with enlightening of modern technologies which combine us in this matter, and taking and to implement to our society the understanding that any type of prophylactics, it's even if it's costly, it's much better than a child with pathology. If we can lobby this idea in our society, then we will have greatest achievements. Thank you very much for your talk. I want to add for this one, I want to appreciate Professor to this. I agree with her for 100%. Is 200,000%. Of course, everybody can use this technology, whoever has money. But the main thing that I wanted to say, that Professor Oa, is that the most important part is like what we doctors as a doctors do with this technology. So whatever will have the NIPT, and then the next time there would be different types of sequenations, the whole genomes, like million analysis can be done. But the change starts that we doctors, we are nurses, we are the people who are in this place. We give to our youngsters that the most important part of that what Israel achieved, that it could deliver to even a baby, that it's very important to plan to do something. It's very important to plan our future. It's not that because you don't have to have spontaneous pregnancy or give a lot of birth or less birth. The main thing is quality. Overall, the whole population would suffer from those mistakes which minorities have done. If very minority will feel bad, then in the end it may end up feeling the bad for the whole society. We as a center, we cannot do this path by ourselves. It's impossible for the population of 9 million. It's impossible for population of 35 million. So we can only do it with the right people, which can do with the other people, at least with those Ministry of Health, if they are very interested in giving this and sharing this information for the whole society. So for this one, we need to work with all who are in one chain as a good thing. They will allow us to decrease the amount of diseases and stop the breaking families and changing the attitude to pregnant people. Because beginning of the family, the beginning of a new life, it should be on a positive manner, not in negative, and people should not suffer from that. The information that we can give, the information we can help to share, to give, to bring the specialists, which would be interesting for you, and to know your any notes to our site regarding the conferences. We would love to take them as into a consideration.
So in the future, of course, we are planning a similar conference on the same topic. That's why I would like to thank the Minister of Health for providing this opportunity to call and to invite everyone in one place. And I would like to also thank the participants for allocating time. I'm more than sure that they have a lot of issues that could have a lot of things that could spend time on today. So the ones who are on the internet, they already registered, so you can go to our website, if you have any further questions now or later on, to the speakers participated today or the organizers of the conference. You can go to the website and just write and send your question. Thank you very much for your time. We very much value your time, and we also hope that it was at least a little bit useful for all the people who have participated today. Thank you very much. Dear colleagues, on behalf of the Minister of Health, would like to thank the organizers of today's conference, and those are the first steps in Uzbekistan on prenatal diagnostics and all this work we are doing here. Hopefully from July 1 those will be put into practice. Therefore, would like to thank you all with that occasion. I would like to thank the organizers. Thank you. The Minister of Health is thanking you for introducing such methods. On behalf of the Minister of Health, would like to thank you, and this is mutual. We also would like to thank you all for coming today, for allocating time. We know that this is a working day. I would like to thank the Minister of Health for their support in organizing today's conference. Would like to thank all the speakers, invited speakers. That was very much interesting.
For your lectures, we are greeting you in our country, and we are very happy that you are with us. Все, спасибо всем.
So that's all. Thank you very much. Hopefully we're going to meet again in the future. The certificates, you can pick them up at the entrance.
Коллеги, не забудьте, пожалуйста, сдать наушники и забрать свои паспорта и документы.